بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم تسليما كثيرا. إخواني أعزائي أبنائي الطلبة، يتجدد بنا اللقاء في محاضرة جديدة بعنوان Understanding Phacodynamics في سلسلة محاضرات Ophthalmology Made Easy. And as I have said before, that the aim of this lecture is targeting all postgraduate students and all junior doctors who are practicing ophthalmology in different eye departments. Now, I would like to stress in this lecture about the importance of understanding the Phaco fundamentals and the Phacodynamics to guarantee and offer a successful cataract surgery for your patients. As I have mentioned in a previous lecture, that cataract surgery became a refractive surgery. So in order to achieve your patient satisfaction and offer him a good result, it is not only the surgeon skills that determines the outcomes. However, it is a spectrum ranging from the preoperative selection and preoperative preparations and understanding the phacodynamics and the surgeon skills. All these variables are very important to offer a very good result for your patients. Another thing, the generation of new types of phacoemulsifications and the huge innovations in the phacoemulsification technology make a confusion within doctors regarding the different new principles of phacodynamics, the principles of the transverse phaco and the microincision cataract surgery, the principles of active fluidics and active phacodynamics. All these principles we would like to emphasize and explain in these lectures. So for you as a successful surgeon, you need to understand the machine that you are using so that you can handle and tackle whatever scenario you face during your cataract surgery. So let's dive deeply in this lecture, and I will show you the advantages of the recent phacoemulsification machines. I hope that you will get benefit from this lecture. And at the end, I would like just to remind you that there is no any financial disclosure from this lecture, and whatever brands or machine names I mentioned in this lecture is just for scientific purpose, and there is no any financial disclosure. When we speak about the phacoemulsification or the phacodynamics, we cannot ignore to mention about two persons. Number one, Dr. Charles Kilman, who is the pioneer of phacoemulsification, and he's the one who applies the phaco machine in the human eyes at 1967. His operation extends for 3 hours, and unfortunately it ended up by aphakia and later on by anterior chamber IOL. The second person is Dr. Barry Siebel, who was the first who introduces the term phacodynamics and the physics behind the closed system phacoemulsification. So these two persons should be mentioned when we speak about phacoemulsification or the phacodynamics, which means the science that deals with the physics of a closed system phacoemulsification surgery. Now, understanding the principles of phacodynamics or the fundamental principles of phacoemulsification machine is very important task for all anterior segment surgeons, because we are facing different types of cataract, from mild degree to moderate degree to a very hard cataract, and also we are facing different types of eyes, small eye, big eye, average sized eyes, and so on. So it is not one size that fits all, so that you just put a fixed parameters for your phaco machine and you use it for all patients. So by understanding the principles behind the phacodynamics, so that you can adjust and modulate your parameters according to the patients, according to the type of cataract, and according to different scenarios that might happen during your cataract surgery. So just because you are driving a sport car, this doesn't mean that you are a good driver. The good driver who understands the machine that he's using, and he can handle any abnormal scenarios that he is not expecting, and end up with a safe surgery and satisfied patients. That's why we need to understand the phacodynamic. It is not just an elective option for you as a surgeon. It is a mandatory for you as a surgeon to properly understand the physics and the principles behind your machine. Now, the intended learning outcomes and the outline of this lecture will be as follows. We will study the ultrasound power and power modulation. Then we will study the different passive and active irrigations. Then the aspiration flow rate and the different types of pumps. And then the vacuum and the surge and the anti-surge measures. In between, we will discuss about the recent advance in the different companies and the different manufacturers. So we will go now to study the ultrasound power and power modulation. Now, when we look to the basic structure of the Phaco emulsification machine, the Phaco emulsification machine basically is made up of an ultrasound delivery system and a fluid circuit. The ultrasound delivery system aims to emulsify the cataractous crystalline lens so that a 10 millimeter cataractous lens can be removed through a small wound ranging between 2 to 3 millimeter. However, the fluid circuit aims to counteract some of the side effects of this ultrasound energy. In the top is the heat generation. You know, the use of traditional ultrasound with the jackhammer effect will create a heat inside the anterior chamber and can lead to some complications. The aim of the fluid circuit is to counteract this heat effect and ensure delivery of the ultrasound and the fragmentation of the nucleus without heat production. The second use of the fluid circuit is to counteract the repulsion effect that is associated with the traditional ultrasound, that's the longitudinal ultrasound. You know, when we will speak about the type of ultrasound, the main one is the traditional, that is the longitudinal jackhammer effect of the ultrasound. So this will create a repulsion to the lens fragments. And to ensure good attraction for this lens fragment to the phaco needle, the fluid circuit, one of its job is to maintain or counteract the repulsion effect of the ultrasound. The third aim of this fluid circuit is to maintain stable anterior chamber pressure and volume so that it can smoothly remove the emulsate from the anterior chamber and ensure safe structures inside the eye without any collateral damage associated with the use of this energy. So if you look to this picture, you can see that the ultrasound delivery system is exemplified in the Phaco handpiece. We will speak about the details of this Phaco handpiece, and the fluid circuit is maintained by the irrigating fluids that through the bottle height. And this fluid is through a special pores in the sleeve will be irrigated inside the anterior chamber, and the removal of the emulsate will be done by the associated pump system present in the Phaco machine, so that the amount of fluid entering to the anterior chamber is equal to the amount exiting the anterior chamber, so we can maintain stable anterior chamber and stable fluidics. This is as simple as that, the basic principles of the Phaco emulsification machine. Now we come to the foot pedal. As you can see that all the functions of the Phaco emulsification is controlled intraoperatively by the surgeon through the foot pedal. So the foot pedal is very important structure joined to the Phaco emulsification machine, because all the functions of the Phaco is controlled by the surgeon through the foot pedal. So you should understand carefully the utilities and the functions of the foot pedal. As you can see that there are 4 positions for the foot pedal. The position 0 is the resting position, in which there is no any functions done and there is no any irrigations or aspiration or any ultrasound, and there is a bench valve closed or attached to the irrigation system, so there is no any irrigation at this position. However, some machines are equipped with free flow. In this free flow, if this free flow is activated, so a continuous irrigations to the anterior chamber will be present even in the 0 position, and only irrigation without any aspiration, and the fluid is driven to the anterior chamber through the hydrostatic pressure of the bottle height. So in normal foot pedal in position 0, there is no any irrigations unless you activate the free flow options. So at that time, a continuous flow will be present to fill the anterior chamber and pressurize the anterior chamber. And the flow will be stopped once the equilibrium established between the hydrostatic pressure in the bottle height and the pressure within the eye. Position 1, when this position is activated by pressing down the foot pedal, you will hear a sound for the pinch valve, and this indicates that the pinch valve is opened so that an irrigation will start appears. As I said, this is usually driven by the hydrostatic pressure of the bottle height. Later on, we will speak about the different types of irrigation, because recently there is what's known as an active irrigation system. But now just I want to speak about the different functions of the foot pedal. Now in the position 1, so there will be only irrigation will appears and driven by the gravity or gravity dependent. In position 2, once you press further the foot pedal, the position 2 will be activated, in which the pump will be start working, and at this time the aspiration will start. So at position 2, you will have irrigation and aspiration at a particular equilibrium to maintain a stable anterior chamber. So position 2 indicate the activation of the pump. Now in position 2 also, in a flow-based pumps, there will be activation of the aspiration flow, which is linearly controlled by the foot pedal in position 2. The more you step down in the position 2, the more you will increase the aspiration flow rate, so that to reach to the preset value. And in a vacuum dependent pump, if it is linearly setted, so the vacuum will be increased. The more you step down to the foot pedal, the more the vacuum will reach to the preset value. However, in a flow dependent pumps, that's the peristaltic pump, the vacuum will not be activated in this stage unless there is occlusion of the tip. Once there is a complete or total occlusion of the Phaco tip, at that time, the vacuum will build up in the aspiration system, and it will reach to the preset value. So this should be clearly understood. In position 1, only irrigation, and there is no activation of the pump. In position 2, because of the activation of the pump, whatever is it, a vacuum dependent or flow dependent, so the irrigation will be there, and the aspiration also will be there. In the flow dependent, the aspiration will be linearly controlled, so the more you step down to the foot pedal, the more you increase the aspiration flow rate. Because in the flow dependent pumps, as you will understand later on, that we cannot linearly control the vacuum unless there is an occlusion of the tip. Once there is an occlusion of the tip, the vacuum will be created and linearly controlled. In the vacuum dependent, from the beginning, once you press or step down into the position 2, the vacuum will be created and will be linearly dependent or controlled, regardless occlusion of the tip in the vacuum dependent. That's the Venturi pumps. Now, once you step down to the position 3, what will happen in position 3? Apart from the irrigation and the aspiration, which happens in position 1 and 2, another function will be added, which is the ultrasound. Now, the excursion of the ultrasound energy will be started or initiated once we reach to the position 3. And now it depends on your preset value. If you set the ultrasound delivery mode as a linear, so the more you step down to the position 3, the more the energy will be delivered. However, if you program your ultrasound delivery as a panel modes means the preset value of the ultrasound will be executed once you press down to the position 3, and the whole energy will be reached once you press in the position 3, regardless you further increase the position 3. So there will be no linear control. The whole amount of the preset value will be executed once you reach to position 3. Now, I would like to remind you here that most of the techniques or the manipulations that's done by the doctors will be taken during position 2. The maneuver, for example, the chopping or the division of the nuclei or of the fragments, or all the maneuvers done by the doctor, usually they done in position 2, in which there is no ultrasound. And once you fragment the nucleus and you want to aspirate them, so you step down to position 3, so that you utilize a minimum amount of ultrasound to facilitate and help the aspiration. And also position 3 is used during the initial sculpting and creating the trench. So position 2 is very important because most of the maneuvers and techniques done in position 2, and in the stage 3, this is the activation of the aspiration and also the ultrasound to facilitate the removal of the emulsative from the anterior chamber. Another point I would like to speak about is the in position 3, if you set the machine in the irrigation aspiration mode. Now, as you know, you can program the machine to be a traditional, that's irrigation aspiration ultrasound. And once you finish your procedure and you reach to the level of epinucleus removal, you can switch on to irrigation aspiration mode. Now, in the irrigation aspiration mode, you will have 3 positions only. You will have the resting position where there is nothing is there, and when you step down to level 1, you are in the irrigation, and then in the stage 2 there will be only irrigation aspiration. This is in the irrigation aspiration mode. This is in normal Phaco. You will have step 1, step 2, step 3. However, if you set the machine into the irrigation aspiration mode, only you will have irrigation and aspiration mode. This is in position 3. Another important point I would like to add that what I have spoken earlier is about the traditional foot switch. Now, recently there is a new modality has been added, which is known as the double linear foot pedal. This double linear foot pedal, the principle behind is that in the traditional type of foot switch, that you cannot jump from one level to one level without reaching to the maximum level. That's to say, you cannot reach to ultrasound unless you pass through complete stage 2 with the full function of stage 2. You will reach to the full preset value of the vacuum in a vacuum-based pump, or in a full preset value of the aspiration flow rate in a flow-based pumps. However, in the double foot switch, the idea that you can jump or switch to the ultrasound mode from stage 2. You need not to have a full parameters in stage 2 to be fulfilled to reach to ultrasound. That's to say, if you you preset your vacuum level, for example, at 200, and in the middle of this 200 linearly programmed, so that at the middle of the stage 2 or position 2, you reach to 100. At that point, you want to switch to ultrasound. Just by clicking the foot switch to the right side, this will execute the ultrasound, and you will have an ultrasound energy at a vacuum level of 100. So you need not to go to the full level of stage position 2 to reach to the position 3. But at any point from stage 2, you can shift to the stage 3. So you can modulate your parameters. Having different parameters, you can have a high vacuum with low ultrasound. You can have a high ultrasound with low vacuum, and so on, by the double linear control. This is very good utility in the recent Phaco machines, especially in Bausch and Lomb, that enables more stabilization and more confidence of the surgeons, and more handling the lens fragment in the anterior chamber. To maximize our understanding of the function of the foot switch, I made this MCQ. All the following are true regarding the side kick function of the foot pedal except. So I explained before about the function of the foot switch, and there is another function of the foot switch which is known as the side kick. The side kick function of the foot switch is to reverse the direction of the bump, and so that any structure that inadvertently catched by the Phaco tip is released. So if by mistake you catch the iris, so you can reverse the direction of the bump so that you release this iris by side kick function of the foot pedal. So if we want to answer this MCQ, all are true except, so we are looking for the wrong answer. The most number one, the most important side kick function of the foot pedal is reflux is true. On kicking, the side switch aspiration flow rate is inverted and the material aspirated is expelled into the anterior chamber. This is true. Yaw side-to-side function. Yaw means the side-to-side function of the dual linear foot pedal in Bausch and Lomb. This function is called yaw. And this is meant to separate the fluidics and the ultrasound to two planes. And this is true. By this function, we separate the aspiration, irrigation, and the vacuum from the ultrasound. The fourth thing carries a risk of anterior chamber contamination. This is true because when the reflux back, the fluid will be pushed into the anterior chamber from the collection bag. So there is a chance or risk of contamination of the anterior chamber and the risk of infection. The last thing is bump rotation stops completely at the reflex, and this is wrong. Actually, the bump will reverse the direction. It will not stop, but it will reverse the direction. So the answer will be number 5. Now we come to the Phaco handpiece, which is one of the most important and integral part of the Phaco emulsification machine, that all the energy and the fluidics is transmitted through this Phaco handpiece. It is made up of a titanium tube that houses the piezoelectrical crystals within the shaft of this tube that transmits the electrical energy to mechanical energy through the Phaco needle. The Phaco needle is threaded through the anterior part of the Phaco handpiece, as you can see here, and is covered by a silicone sleeve. Also, the Phaco handpiece is connected by the irrigation line and the aspiration line. The irrigation line connecting the irrigating fluids that passes coaxial with the shaft of the Phaco handpiece, and through a space between the Phaco needle and the Phaco sleeve through two openings in the Phaco sleeve 180 degrees apart. It pours the irrigating fluid to the anterior chamber. However, the aspiration line, which is connected through the Phaco needle and go through the shaft and of the lumen of the titanium handpiece, and is connected posteriorly by the aspiration tubes to the aspiration pump. This is the main content of the Phaco handpiece. The importance of the handpiece that it transmits the electrical energy connected to the piezoelectrical crystals to the Phaco needle, so it transmitted as a mechanical energy, which is responsible for the through and fro movement of the Phaco needle. So this is the main component. This is the Phaco needle, as you can see, and this is the silicone sleeve, which is covering the Phaco needle from the anterior part. This is the main part or the body of the Phaco handpiece, and connected by the power line that's connect the electricity, and the aspiration line and the irrigation line. Another thing that the mechanical energy that's transmitted through the Phaco needle, usually in all and most of the traditional Phaco machines or Phaco handpiece, is transmitted as a longitudinal movement, and that's through and fro movement that's called longitudinal Phaco. However, you will see in the next slides that there is another modalities of Phaco handpieces that transmits the mechanical energy as torsional movement or as a transverse movement. This is a general overview about the Phaco handpiece. What's the piezoelectrical phenomena or the piezoelectricity? Now, when this phenomena was initially described, it is described when a piezoelectrical crystals is exposed to a compression, like here. This compression will create an electrical current that can be utilized or detected. And the best example for this piezoelectrical phenomena is the ultrasound probe for the B-scan. When the reflected back ultrasound waves are reflected back, it is detected by the transducer in the ultrasound probe, and this will create compression for the ultrasound, the piezoelectrical crystals, and then it creates an electrical current that can be detected as a pixel and displayed on the monitor of the ultrasound. Now, in the Phaco handpiece is the reverse. It is a reverse phenomena that we expose the piezoelectrical crystals with a direct current, and this current will cause expansion for this piezoelectrical crystals that convert it to a mechanical energy. So this crystals, when the electrical current gets stimulating these crystals, it will expand and vibrate in a frequency equivalent to the frequency of the electrical current, and this will be transmitted to the Phaco needle and create the through and fro movement of the Phaco handpiece. This is the principle of piezoelectrical phenomena, and in the Phaco handpiece it is called reversal of the piezoelectrical phenomena. In the P-scan ultrasound it is the piezoelectrical phenomena. Now we need to understand the meaning of Phaco emulsification. Now, as a part of understanding the Phacodynamics, we need to understand the Phaco emulsification. Basically, the Phaco emulsification is simply that we deliver an ultrasound energy to emulsify the nucleus, and then we need to remove this emulsate from the anterior chamber by certain fluidics, so that this removal is very safe to the eye without any turbulence, without any collateral damage to the endothelium or to the posterior capsule. This is as simple as that. So the aim of the fluidics of the Phaco emulsification is to safely remove the emulsate from the eye, and also to keep the temperature or the avoid the thermal effect of the Phaco needle to damage the wound or damage the endothelium. So in the next slides, we will speak about the different modes of energy delivery to the nucleus that emulsify the nucleus. And also we will discuss the modulation of the power or the ultrasound energy that we deliver to the nucleus. Then we will speak about the fluidics, the basic principles and the types, and so on. The new generation of Phaco emulsification machines, as invented by Alcon Company, it introduced the principle of torsional Phaco handpiece. By torsional Phaco handpiece, the mechanical energy created by the piezoelectrical crystals is transmitted to the Phaco needle in the form of a twist or torsional movement with a frequency of around 36 kilohertz. And this torsional movement, in contrary to the traditional longitudinal through and fro movement of the Phaco handpiece, this improves the holding facility, and the shearing effect created will gives better fragmentation of the lens fragment. This is the torsional handpiece invented by Alcon Company. At the same time, the same handpiece, we can have a longitudinal Phaco along with the torsional Phaco. The torsional Phaco handpiece, or the Uzil handpiece, has been invented by Alcon Company at 2006, and this torsional movement means that the Phaco needle is not moving only in the through and fro movement, but it moves along its axis, so that it has a torsional movement. And for the torsional handpiece to function properly, it needs a curved tip that's known as Killman tip. This angulation of the Phaco tip along with the torsional movement both made the torsional handpiece. Now, the advantage of this innovation in the handpiece that it increases the contact time between the lens fragment and the Phaco needle, and decrease the repulsion effect made by the longitudinal Phaco. So it offers a very good holding and good followability, as well as minimize the amount of energy needed to emulsify the lens fragment, as well as minimize the amount of heat production. So many studies done and shows that the torsional handpiece has reduced the surgery time for Phaco too much as compared to the traditional longitudinal Phaco emulsification. The other modality of the Phaco handpiece is the transverse Phaco, introduced by the AMO company, which is known currently as Johnson & Johnson company. This transverse Phaco exemplified by the ellipse FX handpiece. The same principle, the mechanical effect of the piezoelectrical crystals, is transmitted to the Phaco needle as a transverse movement that creates a shearing effect onto the Phaco fragment and improves the holdability and the followability of the Phaco handpiece. And both the torsional and transverse Phaco is a new modalities of the Phaco emulsification that improves the energy expenditure, and hence it will reduce the thermal effect of the Phaco handpiece, as well as improves the efficiency of sculpting and the holding effect of the Phaco handpiece. The transverse movement can be done at a 38 kilohertz frequency, and the longitudinal movement at 29 kilohertz. Both the combination of the transverse and longitudinal Phaco, it will give us a elliptical pattern known as ellipse Phaco. Transverse Phaco handpiece, which is known as the ellipse X handpiece, which is invented by the AMO company, which is known currently as Johnson & Johnson. It makes the Phaco needle moves in the horizontal direction. It has a horizontal movement, and if it is combined with the longitudinal movements, it will give an elliptical pattern. So it is called elliptical Phaco. Now, the same idea, the transverse Phaco has advantage over the traditional longitudinal Phaco by decreasing the Phaco time, decrease the amount of energy, and decrease the repulsion effect of the jackhammer that is seen in longitudinal Phaco, and it improves the followability and the holdability of the lens fragment. So this is another new innovations in the technology of the handpiece manufacturing that delivers ultrasound in both longitudinal as well as transverse mode. Now I will speak about an important integral part of the Phaco handpiece, which is the Phaco needle. The Phaco needle is the titanium hollow needle that is proximally threaded to the Phaco handpiece, and distally it represents the aspiration line. Now, this Phaco needle is very important structure of the Phaco handpiece because all the functions of the Phaco emulsification is translated and transmitted to the anterior chamber through the Phaco needle. For example, the ultrasonic energy, the mechanical energy that's created by the piezoelectrical crystals are transmitted in the form of through and through movement or torsional movement or transverse movement to the lens fragment through the Phaco needle. Also, all the fluidics of the Phaco emulsification, that's the aspiration, is transmitted to the anterior chamber to maintain a stable anterior chamber is passed through the Phaco needle. So the Phaco needle architecture and structure is very important part that determines the efficacy of your Phaco emulsification machine. Now, this Phaco needle is covered from the anterior part by the silicone sleeve, and this silicone sleeve is meant to transmit the irrigating fluid that passes coaxial with the Phaco needle, and through a two horizontal points 180 degrees apart will be transmitted to the anterior chamber and create an eddy current that help or facilitate the emulsification and aspiration of the emulsate. Now, the silicone sleeve also is very important to protect the eye from the temperature that will be generated with the movement of the Phaco needle. In the next slides, we will speak about the heat generation of this Phaco needle and the measures done to avoid the complications of the high temperature of the Phaco needle, like the wound burn. So the silicone sleeve is very important. The Phaco needle should be covered with the silicone sleeve. However, as you know, the innovations of the microincision cataract surgery and the advancement in the power modulation that make the Phaco emulsification cold procedure. So in bimanual Phaco, we don't use the Phaco sleeve because there is no heat production. So we can use the Phaco needle without the Phaco sleeve. Now, in this animation, I will show the functions of the Phaco needle in transmitting the Phaco energy to the lens fragment. As you can see here, this is the traditional movement, and then the oscillation, that's the torsional movement with 20 to 30 degrees semicircular movements of the Phaco needle. This is very important to help and augment the emulsification of the lens fragment. Also, it can be in the form of a combination of both torsional as well as longitudinal movements, and it can be also in the form of transverse movement. So all this energy is transmitted to the lens fragment or to the nucleus through the Phaco needle. Now, the phaco needle can be classified based on different ways. It can be classified based on the shape of the phaco needles, or based on the angulation of the bevel, and based on the lumen of the phaco needles. Now, based on the shape of the phaco needles, we have the standard straight needle, which is the original version of the phaco needles. The first one that has been developed is the straight version. After that, they developed the Kilman tip or the curved tips, which is the Kilman tip or the balanced tip or the sepal tip or cobra tip. All these are curved tip to increase the cavitational effect and has some advantages regarding the internal lumen, so that it will increase the resistance of the outflow, so it gives a more stable anterior chamber. Now, in this animation, I will show how this needle is attached to the phaco handpiece using the winch, and the should be tightly fixed to the handpiece. Otherwise, the ultrasound energy will not be transmitted properly to the phaco needle. And as I said before, that it should be covered with the phaco sleeve. There is for each size of phaco needle its own special phaco sleeve, because the relation between the sleeve and the phaco needle is very important here to avoid the heat production, as well as protect the wound from the wound burn. Now, one of the source of the heat production in the phaco needle is the tight contact between the silicone sleeve and the phaco needle against a tight wound. So this is one source of the heat production made by the phaco needle. So each needle, you should use its own phaco sleeve. Another thing that you can see here, the difference between the Kilman tip and the balanced tip, which is around a 45-degree angulation. In the balanced tip, all are in one axis. However, the Kilman tip, the curve is off axis, and it has a stroke length of around maximum 130 micron. As I remember, I spoken before about the stroke length. The stroke length is the proportion of the needle forward movement of the needle in relation to the total maximum amplitude. Now, this is the maximum amplitude up to 130 microns. However, the balanced tip, you can see that the maximum amplitude is 192 microns. Now, another feature of the phaco needle is what's known as the aspiration bypass system. Now, this is invented by Alcon company, in which there is a small opening in the shaft of the phaco needle. This opening will serve two purposes. Number one, during the tip occlusion, now the vacuum will build up here, so this will result in the heat production because the flow will be eliminated. So this aspiration bypass system, it will allow for some fluid to be injected through this pore, so that it will reduce the vacuum within the shaft of the phaco needle, and so decrease the chance of surge. The other benefit, that by allowing some fluid to passing through this needle, it will cool the phaco needle, because during the cessation of the outflow, the temperature will be very high in the phaco needle. So the aspiration bypass system, this is invented by Alcon company to serve these purposes, to eliminate the heat production as well as protect the eye from the surge. Now, in this animation, I will show how these different tips, for example, this is an Uzil with forward movement with a straight needle. You can see the movement, as well as you will see the balance tip, how it is transmitting the mechanical energy inside the eye. This is the Kilman tip, and this is the opening, the aspiration bypass system, that it meant the emulsification because of this angulation, and also protect the heat production in the Kilman tip is more than the balance tip. Now, the balance tip, the heat production is less, and with the long stroke length, maximum stroke length is more with the balance tip. This is the balance tip. Okay, and this is the aspiration bypass system. Another way of classifying the phaco needles is based on the bevel. Now, the bevel, it means the distal or the terminal end of the phaco needle is the bevel, and it can be of a 0 degree or 15 or 30 or 45 degree. Now 0 degree means that if we draw a perpendicular line perpendicular to the shaft of the Phaco needle, it has no any angulation. However, here, as you can see, there is an angulation. Now the advantage of the 0 degree that it is very easy to be occluded. However, it is not very good in sculpting because there is no sharp edge. However, the angulated or the beveled one, it has very good efficiency in sculpting. The more the bevel, the more the efficiency of sculpting, but it is not easy to be occluded. However, once occluded, the holding power is more because the surface area is more. I will explain this here. For example, as you can see, this is the bevel of the Phaco needle. This is a 0 degree, there is no angulation. This 30 degree and 40 degree. The larger the bevel, the holding force will be more because the surface area will be more. And as you know, the vacuum is a force related to the surface area. As the surface area increase because of the angulation, so the holding power will be more because the vacuum will be more. So this is very important to be understood. The larger the bevel, the cutting will be better. And the larger the bevel, it will be easy to be visualized in the anterior chamber. Sometimes you need to see the tip of your bevel. If it is 0 degree, you cannot see the tip of your bevel. However, if it is angulated, so you can see the tip of your bevel and you see what your level you are at, the lens level or the iris level or close to the cornea and so on. However, small bevels are easy to be occluded. Now, this is the controversy. So you should understand the relation between the size of the bevel as well as the occlusion. It is not easy to be occluded as the angle is more, but once occluded, the force of holding will be more. The third way of classifying the Phaco needle is based on the diameter. The diameter, we have both. We have an outer diameter and we have an inner diameter. And we have a standard needle of a 19 gauge, and we have a micro tip or micro needles of 20 or 21 gauge. Now the standard needle of 19 gauge, it has an outer diameter of 1.1 millimeter and an inner diameter of 0.9 millimeter. Since the diameter is high, so this offers a very good high flow, and the outflow is high and efficient. And this make it less safer for surge protection because once it is occluded and the collapse of the lens fragment, there will be sudden surge to the anterior chamber. Hence, they start thinking how to reduce the outflow or increase the outflow resistance by creating a micro tip so that it has a small outer diameter of 0.9 and inner diameter of 0.7. This will retard the outflow, so it will protect against the surge. However, it is less efficient in clearing up the emulsate from the anterior chamber. Another thing that this is, as you can see in the diagram, the standard tip, and this is the micro tip, which is 21 gauge. And there is another Phaco needle made by Bausch and Lomb, mainly by Barrett, which has double sizes of the internal lumen, so that the outer end is wide, but the inner lumen is narrow. This is to increase the holding power here, because you know the relation between the terminal end and the holding power. The more the distance or the surface area of the terminal end, this will increase the holding power. However, the narrow lumen will increase the outflow resistance, so it will protect against the surge. This is another flare tip made by Alcon company. Same, it is the inner diameter is 0.6. However, the outer diameter is 0.9. So this is different examples. Now another thing I will speak here about the as I spoke before about the ABS. In the ABS, there is an opening here in the shaft of the needle between the sleeve and the needle. And this is very important in protecting against the surge. As I said, when there is occlusion of the tip here, the vacuum will be built up here, and the irrigating fluid will have a space to pass and to neutralize the vacuum here, so that once the fragment is aspirated, there will be no sudden gush of fluid from the anterior chamber and will lead to the surge. So the ABS to protect against the surge. Another thing, the ABS system also to protect against the heat production. Now, the through and from movement of the phaco needle, this will create a temperature in the phaco needle. And once there is occlusion here, the flow will be eliminated so that the temperature will be elevated. So the presence of this opening will bring some fluid here to avoid elevation of the temperature of the phaco needle. Another innovation made by what is known the McCool Phaco tips, in which they incorporate a polymer insulation tube in between the sleeve and the phaco needle. This acts as a barrier for the thermal transmission, so the heat will not be transmitted to the wound by the presence of this insulator. This is as insulator. This is called the micro seal tip. And this was invented by Bosch and Loeb, or also known as McCool Phaco needles. This is the different types of the Phaco needles based on the diameters. Now the second question, all the following are true regarding ultrasound power except. So you have to choose the wrong answer. Now, the more the frequency of the handpiece, the more is the power. And this is true because we said that two variables are important for the power, is the frequency and the stroke length. The more the stroke length, the more the power. This is also true because, as I said earlier, both the stroke length and the frequency are important determinants for the power of the phaco. Now, the larger the pebble surface area, the more the cutting rate of the phaco needle. Now, this is wrong because the large surface area of the pebble have nothing to do with the power of cutting, but it has to do with the holding power. That's the occlusion and the holding power of the phaco needle. So this is the wrong answer. Now, the increased angulation of the tip increases the cutting rate. This is true. The more the angulation, the more the cutting of the tip. As you know already that the zero tip has less cutting rate than, for example, 45-degree tip and so on. Now, zero tip have the easiest holding power. Yes, the zero tip easy to hold and because easy to occlude. Okay, although the surface area is small, but as far as it is easy to hold, yes, it is easy to do occlusion and easy to hold. But the larger surface area, the more is the holding power. So the wrong answer will be the large pebble surface area has increased the cutting rate of the phaco needle. The silicone sleeve is another important structure that insulate the phaco needle and protect the wound from the heat effect of the phaco needle. So it is act as insulator. Also, at the same time, it allow for the irrigating fluid to pass from the two adjacent pores that's present 100 degrees apart adjacent to the phaco needle. As you can see here in this video, this current is very important so that it should not be perpendicular that touch the endothelium, should be at 180 degree. And this current itself is very important that it create an eddy current within the anterior chamber and facilitate to bring the lens fragment towards the phaco tip. So the size of the phaco, the sleeve and the orientation and the distance of the exposed part is very important. This is the normal location. Normally it should be around 1.5 millimeter in the straight phaco needle like this. And if it is too short or too long, this is incorrect and may lead to problems. For example, this is too short exposed part. This may allow the leaking fluid from this area to push the lens fragment when they are close to the phaco needle. So the fluid coming from this part will push the fragment and this will affect the followability. Another thing, if this is very long, so during the forward movement and of the phaco surgeon hand, this pores might accidentally come out of the wound and suddenly will collapse the anterior chamber and lead to a surge. So at a particular stage, it might endanger the posterior capsule. So the orientation and the distance of the exposed part is very important in the silicone sleeve. Now we come to the term phaco power. Now, what are the parameters that determines the phaco power? There are two important variables, that's the stroke length and the frequency. We should understand these two variables. What's the meaning of stroke length and what's the meaning of the frequency? The stroke length refers to the distance by which the phaco needles will move along the longitudinal axis of the handpiece inside the eye. The proportion of that movement relative to the total length of the phaco needle is called the stroke length. For example, if you have the phaco needle 4 ml and it moves 2 ml, so it moves 50% of the total length of the phaco needle. So this is a variable that is surgeon related. That's the surgeon will modify this at the panel of the phaco before he start the surgery. So when we set the stroke length as 50%, it means that the needle will move 50% of its length within the eye, the through and fro movement of the phaco needle. So this is the stroke length. Now the other variable is the frequency. Now what's the meaning of the frequency? This factor usually we cannot modify because it is related to the manufacturer and it is fixed with each type of handpiece. Usually the range of the frequency of the handpiece is between 29 to 60 kilohertz. It depends on the manufacturer, which refers to the number of oscillations per second that it happens. So the distance by which the needle moves is the stroke length, and the frequency of oscillation or the number of oscillation per second is referred to as frequency. And the phaco power is the sum of both. It is the frequency multiplied the stroke length is the total phaco power. So it should be this very clear. Now, if you look here, the phaco power is said to be 40. 40 means 40%. So the phaco needle, this is referred to the stroke length. Now, the phaco needle will move 40% of its length within the eye, 40% of its length. So this is a surgeon variable that can be adjusted and can be controlled by the surgeon by his foot switch. When you set the phaco at 40%, based on the mode you are choosing, whether you are using a continuous mode or pulse mode or linear or panel. So by pressing in the foot pedal in position 3, you can adjust this variable. Now, when we come to the exact mechanism by which the phaco machine emulsify or destroy the lens fragment, there was many studies and many researches done to exactly identify which one is the main cause of the defragment or emulsification of the lens nucleus, and they came up with different postulation. The first and the most common is the jackhammer effect. Of course, now we are speaking about the traditional longitudinal phaco. That's the through and fro movement of the phaco needle within the substance of the lens fragment. This creates a physical degradation of the lens fragment and leading to emulsification of this lens fragment. And perhaps this is the reason for the thermal effect or the heat that is generated. This is the first mechanism is the jackhammer effect. Of course, when we speak about the Uzil handpiece or the torsional phaco or the transverse phaco, the mechanism will be different. This is due to through and fro movement. That's the forward movement of the phaco needle will lead to destruction of the lens fragment. However, the backward movement, there will be no destruction. Unlike the Uzil or the torsional handpiece, in which the torsional movement of the curved tip of the Kelman tip, this will create a shearing effect of the lens matter. So the contact between the lens fragment and the phaco needle is more. So it will cause more emulsification and more destruction. Same thing for the horizontal phaco, that's the transverse phaco. The other mechanism is not related to the mechanical or the physical effect of the phaco needle, but it is related to the cavitation. Now, the cavitation, the sudden and rapid through and fro movement of the phaco needle, the backward movement of the needle, this will create a vacuum in this area, and this vacuum will create a microbubbles. This microbubbles will implode and explode within the lens fragment, and this will lead to emulsification. This is the explanation for the meaning of cavitation. So they claim that the sudden through and through movement of the phaco needle during the backward movement, this will create a negative vacuum here, and this will create a micro bubbles that will implode and explode the lens fragment. Some people say that this is the main mechanism of phaco emulsification. That's the cavitation theory. However, others say that the main mechanism is the jackhammer effect along with the cavitation theory. Now, the third mechanism that assists in the emulsification of the lens fragment is the coupling forces. By coupling forces, we mean that the surgeon will help to emulsify the lens matter by, for example, pressing against the nucleus during the phaco emulsification, when with the other hand using the chopper, he press the lens fragment against the phaco needle, or by the aspiration force. The aspiration itself will help in milking and emulsification of the lens matter. And also by as I said, the second hand, what he did, feeding of the phaco needle with the lens fragment. This is called the coupling forces, that it will help and assist in the phaco emulsification. So the main mechanism is the jackhammer effect, the cavitation theory, and the coupling forces. What are the disadvantages of traditional longitudinal phaco? Before we speak about the disadvantages, we should mention that is there any advantage for the longitudinal phaco? The answer for this, that the longitudinal phaco is very useful in the initial stages of phaco emulsification, in the sculpting and the trenching, especially in very hard nucleus. So in the presence of very hard nucleus, the longitudinal traditional phaco emulsification, whatever mode used, either continuous mode or pulse mode, is very effective in cutting and destroying the lens fragment. However, the development of the disadvantages of this ultrasound and the development of new generations of ultrasound delivery system, this make the use of the longitudinal traditional ultrasound is limited only for certain indications. We will speak about them later. So the first disadvantage of the longitudinal phaco is that it produces a repulsion effect. If you can see in this animation, that the repulsion effect due to the through and fro movement of the needle, so the fragment will be pushed backward and coming back again. And so in the traditional longitudinal phaco, you need to increase the vacuum setting, so that when the lens fragment is repelled away from the phaco needle, it should be retracted again by the increasing the aspiration flow rate and also increasing the vacuum setting, especially in the Venturi pumps. We will speak about this later. So the phaco emulsification is an balance between the repulsion effect of the traditional longitudinal phaco and the aspiration flow rate, or the vacuum, in the other hand, to keep the lens fragment steadily in touch with the phaco needle. As you can understand later when we speak about the torsional phaco and the transverse phaco, now this problem is overcome by the torsional handpiece with the use of Kilman tip or the transverse tip, so that there is no repulsion effect. Now, when we speak about the other modes of ultrasound, we will not have a repulsion effect in transverse phaco or in Ozil or torsional phaco emulsification. The other disadvantage, because of this rapid through and fro movement, this create a thermal effect which is endangers the wound construction. That's why we need to use a sleeve, a silicone sleeve on the phaco needle to protect the wound from the heat production. Another thing, because of the phaco is just in contact with the lens fragment in the forward movement, while in the backward movement there is no contact with the lens fragment, so the efficiency is reduced to the 50%. Unlike the torsional phaco and the transverse phaco, in which the lens fragment continuously in contact with the phaco needle. So in the longitudinal phaco, the phaco needle only in contact with the lens fragment during the forward movement. So the efficiency of the longitudinal phaco is less as compared to the torsional and transverse phaco. And as I said before, that because of the thermal effect, the corneal endothelial damage also is more because of the thermal effect, also because of the energy expenditure, because since the efficiency is reduced to 50%, so we need to use more ultrasound energy to destroy the nucleus, and this will be affecting the corneal endothelium. So another thing, we need to do some modification and modularization of the continuous ultrasound in the traditional phaco, so that we reduce or minimize the hazards or the side effect of this modality of ultrasound delivery. Unlike in the Uzil or the transverse phaco, no much modulation is needed. By modulation, I means that we need to modify the delivery system of the ultrasound. And instead of continuous ultrasound, we need to shift to pulse ultrasound or burst ultrasound or micro pulse or cold phaco. However, in the torsional or horizontal phacoemulsification, we don't need that much modulation as we need it in the longitudinal phaco. The last thing is that because of the repulsion effect of the phaco needle, so the followability will be reduced. The followability means the attraction of the phaco needle, the attraction of the lens fragment towards the phaco needle. Since the phaco needle will create a repulsion for the lens fragment, so the followability and the time by which the lens fragment is in contact with the phaco needle will be reduced. So this is all the disadvantages of longitudinal phaco that make doctors and manufacturer of the big companies to look for another alternative way of ultrasound delivery by the use of the Uzil, Handpiece, or the Transverse Phaco, or also by the modulation of the ultrasound or power delivery. Now the third question regarding the choose the wrong answer regarding the pump system. So we have to choose the wrong answer only. In the flow-dependent pumps, that's the peristaltic pump, only the vacuum can be adjusted preoperatively. This is wrong because we said that both the aspiration flow rate and the vacuum can be adjusted in peristaltic pumps. Only vacuum can be set preoperatively in Venturi pump. This is true because only the vacuum that's linearly controlled by the Venturi pump. However, the aspiration flow rate is indirectly controlled by the vacuum. So we can set preoperatively only the vacuum. Now, followability is a function of the high vacuum. This is wrong because the followability is a function of the aspiration flow rate. The vacuum responsible for the holding power or the attractability, the holding power of the fragment. The followability is a function of the aspiration flow rate. The grip power of the phaco tip is related to the high vacuum. This is true. And the venting is meant to neutralize the high vacuum during the full occlusion. This is true. So the wrong answer is number 1 and number 3. Okay. Now, after finishing studying the different types of phaco handpieces, now we will study the physics of the ultrasound energy. We will study the details of power delivery and the power modulation, and even the advanced power modulation and advanced or recent generation of phacoemulsification. So we will study the power in the form of ultrasound, continuous ultrasound, pulse ultrasound, and burst ultrasound, and the advanced modulations in this regard. As you know that we have explained before that the ultrasound can be delivered as longitudinal ultrasound, or as a torsional ultrasound, or as a transverse ultrasound. This is grossly, but at the wave level, the ultrasound can be delivered as a continuous mode ultrasound, and this continuous mode ultrasound can be either as a fixed value or known as a panel mode, in which the whole amount of energy is delivered once you step down in the position 3, or it can be linearly controlled by the surgeon, in which there is a linear increment in the power of the ultrasound as the surgeon presses more in the position 3. Or it can be as a pulse ultrasound, and by pulse we mean that there is fixed intervals between the pulses, and similarly it can be as a fixed mode, that's the whole amount of pulses delivered at once, or as a linear mode that is increasing gradually as the surgeon presses the foot pedal. Or it can be as a burst mode, in which there is different variable intervals between pulses, so that given as a fixed amount or linearly controlled by the surgeon. As the surgeon presses down in the foot pedal, the interval between pulses will be shortened, and the whole amount will be delivered at the end as a continuous ultrasound. So this is the different types of of ultrasound delivery. We will study one by one each one of these and know the advantage of each type and the Phacodynamic for each one. One of the important definitions that we have to understand properly before we speak about the ultrasound modulation and to understand the difference between pulse burst mode, hyperpulse, and hyperburst mode is the meaning of a duty cycle. This should be very clearly understood. Now, one pulse consists of an on time and off time. All the time taken up to the beginning of the second pulse, this is the time for one pulse. That's the include the on time and off time. It means that this is the time where the needle is moving, and this is the time where the needle is resting. So when we say that the duty cycle is 50%, it indicates that 50% of this time is on and 50% of this time is off, because the duty cycle equals to the on time divided by both the on and off time. This is as simple as that. This is the duty cycle. So if I say that the duty cycle is 20%, for example, it means that the on time is 20% of the time, and the whole interval or the whole duration of the pulse is 100%. So 20% only on and 80% is off. When I say the duty cycle is 70%, it indicates that 70% is on and 30% is off. This is the meaning of duty cycle. So in case we want to increase the cutting rate of the ultrasound energy, we have to increase the duty cycle. But if we want to increase the resting of the phaco needle to improve the followability of the fragments, so we have to decrease the phaco cycle. By decreasing the phaco cycle, you increase the resting time, the off time. So this increases the followability. So that you can interplay between these two variables, that increasing the duty cycle will increase the cutting rate of the ultrasound, and decreasing the duty cycle will decrease the cutting rate but will increase or improve the followability. This should be very clearly understood, because there is a lot of confusion between doctors who don't know how to increase the energy. Is it by increasing the ultrasound pulse rate, the pulse per second, or increasing the duty cycle? Now, the ultrasound pulse rate, which is the pulse per, means the number of pulses per 1 second. Now, for example, if you look to this example, this is 2 pulses per second. So you can deliver the whole energy divided in 2 pulses. But if you increase the pulse rate by 10 pulses per second or 8 pulses per second, as in this example, so the same amount of energy is delivered but divided into 8 pulses. So the net result, the whole amount of ultrasound energy is given is the same. There is no difference between the two. This is very important. So you can see in this example that the absolute phaco energy or the absolute ultrasound energy is equal either between 2 pulses or 8 pulses per second, because the whole amount is divided. This should be very clearly understood. So to increase the power or the cutting rate of your ultrasound, you have to increase the duty cycle, but not the pulse per second rate or the ultrasound rates. This is very important. Still in the context of the duty cycle, we should understand this important relation between the duty cycle and the pulse per second. All of us agree that we want to have a good cutting power or emulsification power of the phaco needle, and also at the same time we need to have a good holding power of the lens fragment. Now, these two variables are very important for successful emulsification. If you have a very good power with very good holding, this will end up with good emulsification. Now, by playing with these variables, so you can adjust and modify your variables to achieve this goal. Now, for good cutting power, as I said before, we will increase the duty cycle. So if you increase the on time in the duty cycle, this means that you increase the duty cycle, and hence you increase the cutting power or the emulsification power of your phaco needle. But the problem that once you increase the duty cycle and becomes more than 50%, this will decrease the off time. And as you know that the off time is very important for two things. It is useful in cooling up of the phaco needle, and it is during this time that the vacuum will hold the lens fragment. So by increasing the duty cycle, you increase the emulsification power on the expense of the holding power. so the holding ability will be reduced. So you have to adjust between those two variables. So what you will do in this situation, the reverse is true for the pulse per second. Now, if you increase the pulse rate, increasing the pulse rate will decrease the holding ability. However, decreasing the pulse rate will increase the holding ability. So to have an ideal and proper emulsification, that you have to have a high duty cycle that improves the cutting power and decrease the pulse rate to improve the holding ability. So keep it like this: when you increase the duty cycle, better to decrease the pulse per second, or the pulse rate. If you increase the pulse rate, you have to decrease the duty cycle, like this. So the aim is to have a very good emulsification and very good holding power. In this slide, I will give a practical example of the variation between the duty cycle and the pulse rate. Now, as I explained before, the duty cycle is equal to the on time divided by the sum of both the on and off time. If you have the on time, for example, 6 milliseconds, and the off time is 12 milliseconds, so the duty cycle will equal to the on time, that's 6, divided by the on plus off, that's 18 milliseconds. So the duty cycle will be equal to 33%. So in a case of hard cataract, we use a high duty cycle of around 50%, but low pulse rate around 10 to 15 pulse per second. And this is usually in Phaco 1, that's the trenching, or in the beginning of the surgery. In a case of soft cataract, you need to have a low duty cycle because there is no much cutting. So you can decrease the duty cycle to 20 to 30%, but you will increase the pulse per second to 60 or to 100 pulses per second. So by this way, you will achieve the goal of having a high cutting rate with a good holding ability. Now, the first mode of ultrasound delivery system is the continuous mode. As we have explained regarding the stroke length, the power of the ultrasound represent the amount of the phaco needle, the excursion or the forward movement of the phaco needle. Now, when we say that the ultrasound power is 50%, indicate that the phaco needle will just move 50% of the stroke length of the needle. So if it is 60%, indicate that 60% of the stroke length of the needle, then it will move. So the ultrasound continuous mode can be arranged in a surgeon mode or a linear mode that is arranged by the surgeon, or a panel mode that's a fixed value arranged stored in the machine itself. Now, if we choose the linear mode of the ultrasound, if we say, for example, 50% ultrasound, so the moment you press in position 3, so the ultrasound energy will start gradually to increase from the beginning of position 3 to the middle of position 3, then the end of position 3. So there will be linear acceleration of the power of the ultrasound. Here, for example, we choose the ultrasound power to be 100%. So this indicates that the more you press the foot pedal, you will reach to the 100% of the length of the stroke length of the phaco needle. However, here you will reach only to a 50% of the stroke length of the phaco needle. Now, the other mode is the panel mode, that the amount of ultrasound from the beginning of position 3 up to the end of position 3, it is the same. So if you fix it, the value as a 50%, so it will be 50% from the beginning till the end of position 3. This is the meaning of the panel mode. This is the first mode. This is the continuous ultrasound mode. The second mode of ultrasound delivery system came as refinement of the continuous mode. The drawback of the continuous mode is the amount of heat delivery and heat production, because there is no rest interval between pulses. However, in the pulse mode, there is a fixed resting intervals between the pulses. So this will give us better cooling effect of the phaco needle. And for the pulse mode, we have different parameters to describe the mode of the energy delivery. We have the number of pulses per second, how many pulses per second we can deliver. and we have to fix the amount of ultrasound energy, which is usually fixed linearly, usually made in a linear mode. For example, when we say the ultrasound power is 50%, so the more you step down in the foot pedal from position 1 to position 2 to position 3, the ultrasound energy will increase gradually to reach to 50% of the stroke length. And the other parameter is the duty cycle. Now, I will explain in the next slide about the meaning of duty cycle. But for example, in here, the duty cycle is 40. It means that the duty cycle, the on time is 40%. Of course, usually and commonly in the traditional ultrasound, we use a fixed duty cycle that is 50 by 50. For example, in this example, this is one duty cycle is made up of one pulse on time and off time. So this indicates 50% on time and 50% off time. This is the usual traditional pulse. However, when in the next slides we will speak about the modulation of the duty cycle, we will explain later on about the hyper pulse and the hyper burst mode. So for the pulse mode, we need 3 parameters to describe. We need to describe the amount of energy. We fix it by percentage, for example, 50 or 60%. We need to determine the number of pulses per second, how many pulses per second, and we need to determine the duty cycle, which is commonly in the traditional ultrasound pulse is kept to be 50-50. Now, in this example, we have 2 pulses per second, you can see here, and in this example, you can see that we increases the pulses to 4 pulses per second, so that we have 4 duty cycles. Now, the traditional pulse can range between 10 up to 20 pulses per second. This is the maximum for the traditional pulse, between 10 to 20 seconds to 20 pulses per second. Now, the advantage of the pulse ultrasound over the continuous ultrasound, that the presence of this resting interval between pulses, this is very important, that it improves the followability of the fragments, because during this time there will be no repulsion effect of the ultrasound, so the lens fragment will be with the help of the vacuum will be followed and attracted by the phaco needle, and this will give the chance for the next cycle of pulse on time pulse to do fragmentation of the lens fragment. Another thing, that the resting time here gives time for the needle to cool and decrease the amount of energy production. So this is the main advantage of pulsed ultrasound as compared to the continuous ultrasound. The third type of the ultrasound modulation is known as the burst mode. Now, the burst mode differs than the pulse mode, that by pressing in the foot pedal, we are modulating the interval between pulses, but we are not modulating the power of the pulses. The power of the pulse is already preset as a fixed value, for example, 50 or 60 or 70%. However, the interval between the pulses, we adjust it by the pressing on the foot pedal. So the more you step down on the foot pedal from the beginning of position 3 up to the end of the position 3, so you will shorten the interval between pulses, so that you will, at the end of position 3, there will be a continuous pulse. So we have only to modify only the power, we put it in the machine. Otherwise, the pulses will be shortened, the interval between pulses will be shortened based on the pressing between the pressing of the position 3 up to the end of position 3. Now, what we have to fix is the burst duration. We make it, for example, 125 milliseconds, so that the duration will be gradually decrease up to it becomes a continuous ultrasound. So the burst mode is we modify or modulate the interval between the pulses, that's the duty cycle, and we don't modify the power of the ultrasound by pressing on the foot pedal. Now, before I go to the advanced modulation of the phaco setting, and after we finish the basic modulation, that's the continuous and the pulse and the burst mode, I would like here to mention the statement of Mary Sibyl that pulse and burst mode is contraindicated in sculpting stage of phacoemulsification. Sculpting stage is the first stage of trenching and making the trench in the lens nucleus. He said that the pulse and the burst mode is contraindicated during this stage, and the explanation that For the pulse and the pulse mode to properly functioning, it depends on two variables. The first variable, we need to have a complete occlusion of the aspiration port of the phaco tip, so that the vacuum will hold the lens fragment properly against the lens needle, and the pulse and the pulse mode will do its job in emulsifying the lens fragment. The other thing is that the lens fragment should be freely mobile, so that it will be engaged and re-engaged to the phaco needle, so that the pulse and pulse mode will, during the on time and off time, will do emulsification of the lens fragment. And both these two factors are not present during sculpting, as you know, since the phaco needle is moving against a static and stationary lens nucleus, the inertia of the lens nucleus, so there is no complete occlusion of the phaco tip. Another thing, the lens is fixed and is not freely mobile. So this picture, along with the fast movement of the phacosurgeon handpiece, this will exert a severe stress on the zonule of the patients, and may lead to the nucleus will be fall down or tear in the zonule of the patients. So he advised, and he actually contraindicate the use of the traditional pulse or burst mode in sculpting stage. However, when we will go to the next step, which is the advanced modulation. By advanced modulation, I mean the appearance of the hyperpulse and the micropulsed mode. So at that stage, the cutting edge of this pulse and burst will be much more, and can be used during sculpting. So it is not advised, if you use a pulse rate less than 12 or 15 pulses per second, not to do sculpting with this. It is better to do the continuous ultrasound rather than the pulse ultrasound. This is what I would like to remind you regarding this. So it is contraindicated to use the traditional pulse or burst mode in sculpting stage. Now, on the next slide, we will speak about the advanced modulation. That is, the new generation of phacoemulsification machines have invented a new modulation of the ultrasound to overcome some of the drawbacks of the traditional pulse and burst mode, and improve the followability and the holdability of the phaco tip, and also further minimize the ultrasonic energy expenditure and the dissipated ultrasound energy. Another new modulation of the ultrasound pulse made by the major companies, that's the Alcon and Bausch & Lomb and the Johnson & Johnson company, is the hyperpulse mode. Now, the hyperpulse mode made to combine the advantages of both the pulse and the burst mode, and to overcome some of the disadvantages of these modes. Now, the combination resulted in a linear control of the ultrasound, as you can see here in the hyperpulse mode. So the more you step down the foot pedal, the more the energy power will be delivered. And at the same time, there will be a choice for a reduction of the duty cycle, so that the off time will be more. Now, as you can see in this example, the duty cycle is 25%. So there is a 25% of the time on time, and 75% is off time. Within a 1 second, you have 10 pulses. So this will improve the followability and improve the thermal protection. For example, if you can see in this slide, now the attraction of the lens fragment will be increased and more during the off time. So the lens fragment will be opposed to the phaco needle, so that in the next cycle of the on time, the phaco needle will find the fragment is well opposed to the phaco needle, and this will improve the fragmentation of the nucleus. Now, you can imagine more if this modulation is combined with torsional effect or transverse effect. So this will increase the shearing effect and the degradation of the lens fragment. So this new innovations in the modulation of the ultrasound has improved the followability and improved the thermal protection, and also it decreases the phaco time. The phaco utilized during the operation is much more reduced, and as a result, this will improve and decrease the complication that might happen due to the endothelial damage and so on. So the hyperpulse mode is new innovations in the pulse delivery mode to combine the advantages of both the pulse and the burst mode together. So you will have a linear ultrasound with the ability of reduced duty cycle, as you can see in this picture. Now, what are the pros and cons for the pulse and burst? Now, each type of ultrasound has an advantage. Now, the continuous mode of the ultrasound has a very high cutting rate, and this make it very suitable in the beginning of the surgery, especially in scalping and in very hard nucleus. However, the disadvantage of the continuous mode is the amount of energy production and the thermal production making the risk of endothelial damage is more and the wound burn is more. This is why the modulation to a pulse and burst mode make it better than the continuous ultrasound. However, the pulse and the burst modes, both of them has advantages that to improve their followability. As I said earlier, that during the off time of the duty cycle, the lens fragment will be attracted to the phaco needle by the vacuum, and this will improve the followability of the lens fragments, and this will lead to better and decrease overall phaco time, and also better production of the energy and less energy production. And also the pulse has advantage over the burst mode that it has a linear control of the power. As I explained earlier, that in the burst mode there is no linear control of the power. Once you fix the power into the machine, you cannot increase the power by your foot switch. This option is available in the pulse ultrasound, that we have a linear control. And disadvantage of the burst, as I said, that there is no linear control of the power of the ultrasound. Another thing that the advantage of the burst mode, that theoretically if the duty cycle is kept less than 50%, so the energy production or the heat production by the burst mode is better than that in the pulse mode. So the burst mode, as far as the heat production, is better than the pulse mode. So that's the surgeon, based on what stage of phaco surgery he can change between the continuous pulse and burst mode based on the stage of operation that he's on. Usually the continuous mode is used during scalping and during the beginning of the surgery. The pulse and burst modes are used in stage 2, that's during quadrant removal or lens defragment. However, sometimes few pulses of burst mode are used during chopping to engage and incorporate the phaco needle in the nucleus. So you can change between different types of ultrasound during the different stages of the phaco surgery to secure very safe and very effective energy delivery and maintain a good outcome for the patient. Although the innovations of the modulation of the phaco power by the development of the pulse and burst mode and further understanding of the role of the duty cycle in the absolute phaco time and the total dissipated energy delivered, and doctors became able to address some of the drawbacks and disadvantages of the continuous pulse phaco. Now, the problems of the heat production has been minimized, and the repulsion effect of the longitudinal ultrasound has been refined, but with the trend towards a small incision cataract surgery or micro incision cataract surgery, and the need for a very safe energy expenditure and very safe phaco procedures, the need for further refinement of this ultrasound modulation was needed, and the advanced power modulation developed, especially after understanding the role of the duty cycle. Now, by advanced power modulation, we mean the pulse mode, the hyperpulse mode, that we can deliver pulse up to 120 pulses per second, and the micro burst mode, that we can deliver the burst up to 3 or 4 milliseconds per burst. All of this, along with the innovations in the shaping of the pulse delivered to the system, has been, all these factors has improved to large extent the energy expenditure and the safety of the procedures and make the doctors able to do a very safe procedure known as cold Phaco. Cold in the sense that there is no heat production and very minimum risk of wound burn or any endothelial damage because of the very minimum heat production. So if you can see in this picture in the diagram, this is the continuous ultrasound. The red color indicates the heat production, and the development of the traditional pulse has improved to large extent the heat production, so that at the beginning there is a cold tip, then it becomes warm, then the resting interval between pulses make it cool, and then and so on so. But at the end still you have some heat production. Now the development of the white star technology or the hyperpulse technique make the temperature very minimum and no any energy production. So this enables doctors to perform a sleeveless Phaco or without sleeve and by manual Phaco emulsifications, and known as the cold Phaco. So in the next slides we will see how the advanced power modulation has improved to large extent the Phaco procedure and make it a very safe and very effective procedure. In this slide, you can see that the modulation of the pulse to a hyperpulse mode, known as the cold Phaco, like the serrated knife, in which this is the continuous ultrasound. So the knife is like this. However, when they make the pulse mode that's up to 16 to 20 pulses per second, the knife like this. And with the development of the hyperpulse up to 120 pulses per second, the knife becomes very fine like this. So this is advanced power modulations, and this was because of the understanding of the rule of the duty cycle. As you know, in the traditional pulse, the duty cycle was 50-50, so that there is a 50% of the duration on time and 50% off time. This off time is very important in delivering the vacuum, so that improve the holding capacity of the Phaco tip. Also, the cooling effect of the Phaco tip. Now, with the modulation of the traditional ultrasound to a hyperpulse mode, now the duty cycle has been increased like this. In this example, only 20% is on time and 80% is off time. So the cooling effect is more here, and also the holding capacity will be more because the more time is allowed for the vacuum to hold the lens fragment. So this mode improves to large extent the Phaco procedure, and the shift from continuous mode to hyperpulse mode enables surgeon to perform a cold Phaco procedures. The fourth question, all the following regarding the ultrasound power modulation, we have to choose the correct and the wrong answer for each statement. Now, the duty cycle is a fixed 50-50 duty cycle in pulse mode. This is true because we said that in traditional pulse, the duty cycle usually is 50-50. However, in the hyperpulse mode, there is variation of the duty cycle. It can be 20-80 or 70-30 like this. In linear ultrasound mode, fixed energy level delivered on position 3. This is wrong because in linear mode, the more you step down the foot pedal, the more the energy. So there is no fixed energy level. So this is wrong. Now, the smaller the duty cycle, the larger the off time. This is true because if you have small duty cycle, it means that the off time is more, and the reverse, and vice versa. The higher the pulse per second, the more the absolute Phaco power. Now, this is wrong because we said that the pulse rate has nothing to do with the absolute Phaco power. Now, when you increase the pulse rate, the absolute Phaco power will be the same, but you will increase the number of pulses per second. So the increase in the pulse per rate will not change the absolute Phaco time, but the duty cycle, changes in the duty cycle or increase in the duty cycle, this will change the absolute Phaco power. Longitudinal energy loss more than torsional energy loss. This is true because when we say longitudinal energy loss, we mean the traditional jackhammer effect of the ultrasound. So the cutting rate only when there is forward movement. In the backward movement, there is no cutting. So you lost 50% of your energy is not used in the cutting. However, in the torsional energy, that's in the torsional ultrasound, since the phaco tip is continuously in touch with the lens fragment, so there is no loss of the energy. All the torsional power will be translated to the fragmentation of the lens nucleus. However, in the longitudinal, only the cutting when there is forward movement of the needle, but backward movement, there is no cutting for the fragment. So the energy loss is more in longitudinal phaco as compared to the torsional phaco. So the answer will be like this, okay? Another advanced phaco modulation or the power modulation is the microburst. And this microburst indicates that by variability of the duty cycle, we can give or deliver a very small burst of ultrasound with a limited or predetermined duration, and also with variable duty cycles, so that the off time, we can control the off time between pulses, so that the more you step down in position 3, the more the intervals will be shortened between pulses, so that at the end becomes a continuous pulse. For example, you can see here, this is the burst mode. Now the duration between pulses, the more you step down in position 3, the duration will be shortened, so that by the end it becomes a continuous pulse. And already the power of these pulses is predetermined in the panel of the phaco before you step down the foot pedal. And also you can determine the duration of each pulse. Now in the microburst mode, we can deliver bursts of up to 4 milliseconds per burst. In the traditional burst, it was up to 30 milliseconds. Now in the microburst mode, we can deliver up to 4 milliseconds. You can see here, they incorporate this mode in the intelligent phaco tip, so that it will predict the occlusion of the tip, so that small burst of ultrasound will be delivered to overcome the total occlusion of the tip. As you can see here in the curve, once the total occlusion of the tip achieved, the vacuum inside the phaco tip will be elevated, so that small burst will be delivered here and here and here, like this, so that once the burst is delivered, the fragment will be dislodged and absorbed by the phaco tip, so the vacuum will drop down. Again, when there is total occlusion, the vacuum will be elevated, and another small burst of ultrasound will be delivered here. So this is one application of the micro burst mode in the intelligent phaco handpiece invented by Alcon company. Another use of the micro burst mode is used during the direct chop technique, in which to impale the lens fragment within the phaco tip. Initially, a small burst of ultrasound is given to the lens fragment to impale the phaco needle into the lens nucleus, and then a direct chop or vertical chop or horizontal chop is done. So this is another achievement or advanced power modulation, is known as the micro burst mode. The third type of the advanced power modulation is known as shaping of the pulse or ramping up. By the meaning of ramping up or shaping of the pulse is that we can adjust the rising time of the pulse. Now the traditional pulse will be like this. The full power of the pulse will be given immediately, so that the shape will be like this. However, by ramping up and we adjust the rising time, so the rising time will be slowly like this up to it reach to the maximum energy of each pulse. Now the advantage of this ramping up of this pulses, which is present in the recent phaco machine, is to reduce the repulsive effect of phaco. As you know, the phaco has a repulsion effect that will pushes the nuclear fragment away from the phaco tip, and this is due to the jackhammer effect. And also by the ramping up of the pulse, this allowed the time for the vacuum to attract and hold the lens fragment against the phaco needle to be emulsified by the next coming power of the pulse. So the ramping up or the shaping of the pulse is useful in both decreasing the repulsion effect of the ultrasound and increase the attraction of the fragment to the phaco needle. This is another way of advanced power modulation known as shaping of the pulse. To summarize this part of the lecture that we have spoken about the power and the power modulation, the understanding of the Phacodynamics of the power delivery and the power modulation is very important to offers you a very clear cornea immediately after the operation. the minimum the energy you deliver to your patient, the better will be the result and the less will be the complication. And for you as a beginner or as a phaco surgeon, you should follow certain steps to determine, or I mean reduce your energy expenditure and your energy need by following some steps, like you depend on the mechanical disassembly of the nucleus, like the direct chop. This will minimize your need for ultrasound energy for trenching, and also decrease the time that you press in the foot pedal for the ultrasound, and decrease the maximum phaco power setting. You have to have minimum phaco power setting, and also the power modulation in the form of pulse, mode, and burst, and the advanced power modulation and the shaping of the pulse. All these variables will ensure a minimum energy delivered to your patient, and as a result, there will be a minimum clouding of the cornea immediately in the second day. Now to remind you that we have finished the first item, which is the ultrasound power modulation. Now the next item we'll discuss is the passive irrigation and active irrigations. The first parameters in the fluidics of the phaco emulsification is the irrigation. And the irrigation can ranges from a gravity-based irrigation to a pumped irrigations. And the pumped irrigations, we have two types: the pressure-based, that's the adaptive optics, and the active fluidics. Now, for the gravity-driven irrigation or gravity-based irrigation, based on the bottle height, so you have a fixed bottle height that maintain a hydrostatic pressure difference between the atmospheric pressure and the intraocular pressure. Now, this level of infusion maintains the stability to some extent in the anterior chamber. However, the fluctuation in the anterior chamber due to the increase in the aspiration flow rate or the increase in the vacuum or in the surge, this type of irrigation does not cope with the changes in the anterior chamber and cannot compensate for the leak that happens in the wound. So now most recent phaco emulsification machines, they don't depend on the gravity-based infusion, but based on the pumped infusion. So the gravity-based infusion is mainly related to the bottle height. The more the bottle height, the more the irrigation pressure. Also, it is related to how much vacuum you have in the system, how much aspiration flow rate, and how much the leakage from the wound. So you can see from here that to keep the a fusion pressure of 11 millimercury, you have to elevate the bottle height to a 15 centimeter. If you elevate the bottle height to a 30 centimeter, you will have a 22 millimercury fusion pressure within the eye. And for a 60 centimeter, you have a 44 millimercury infusion pressure within the eye. What are the limitations of the passive irrigation or gravity-based infusion? As I said earlier, because you have a fixed bottle height, this will not satisfy the changes of the intraocular pressure inside the eye during the operation. As I said, when you set the infusion rate, you set the aspiration flow rate at a particular level. As you know, the aspiration flow rate is linearly controlled by peristaltic pump. So the more you press the foot pedal in position 2, the more will be the aspiration flow rate. However, you have a constant infusion pressure. So this makes the pressure inside the anterior chamber is dynamic, is not static, and this will not maintain a stable anterior chamber. So the stability of the anterior chamber based on many variables in the aspiration flow rate, and the incisional leakage, in the vacuum setting, and the tubing and the compliance of the tubing. So the static infusion pressure is not useful to cope and handle all the situations that happens during the operations. And as I said, that some doctors, they keep it at a very high level of the bottle to maintain a very high pressure, and this may maintain a stable anterior chamber to some extent, but this is not useful in many aspects, that it exerts stress on the zonule, and also it might lead to leakage to the vitreous and causes vitreous hydration. And also it will increase the leakage from the wound and from the incision. So basically, because of these limitations of the passive infusion system, companies start thinking of doing a pumped infusion system that's maintain the physiological high pressure within the anterior chamber, and to take in consideration the different situation that happens during the operations, during the occlusion and during the high aspiration flow rate or high vacuum, and also to compensate for the wound leakage. The second type of irrigation, as we mentioned before, the first type, which is the passive irrigation or gravity-based irrigation. The second one is the pumped irrigation or active irrigation. This is usually programmable and connected to the computer system of the machine, and it has a rapid detection of the fluctuation of the intraocular pressure and compensate for any drop in the pressure by injecting or increase the infusion pressure. We have three varieties of the pumped infusion. It can be by injecting air into the irrigating fluid so that the irrigation fluid will enter the eye with pressure, which is known as adaptive optics, as seen in pouch and plomb, or by placing the BSS bag within two motorized plates, which is seen in Alcon company, which is called an active fluidics, or the next generation, which is seen in the Sentry, is the use of the active Sentry handpiece, in which there is a pre-loaded sensor in the handpiece that senses the fluctuation of the intraocular pressure and is connected to the motorized plates around the infusion bag, and also with the Phaco cast, so that it can moment by moment adjust the intraoperative pressure. So we will see in the next slides the meaning of each one of these types of pumped infusion. Now, what are the advantages of pumped infusion? Pumped infusion, you can control the intraocular pressure, and you can set a target intraocular pressure for your operation based on the situation of the patient, based on the associated problems inside the eye, like the presence of zenule weakness or the presence of subluxation of the lens and so on. And it has a minimum of fluctuation in the anterior chamber because there is no fluctuation in the intraocular pressure, and this make the operation more stable and more safe, and the risk of surge is minimum as compared to the gravity-based infusion. Another thing that in the pumped infusion we have three types. We have the adaptive fluidics invented by Bausch and Lomb, in which there is injection of air inside the PSS bottle. And also we have the active fluidics invented by the Alcon company, in which the PSS bag is placed within two motorized plates that senses the fluctuation in the pressure and moment by moment compensate for any fluctuation in the intraocular pressure. And then a final evolution in the Alcon, which is addition of the Sentry, active Sentry handpiece, in which there is a sensor within the handpiece itself that senses the fluctuation or the changes in the intraocular pressure. We will explain about this in the next slides. In general, the pumped infusion is the new trend in all the new machines to use a pumped infusion so that it can compensate for any leakage from the wound and can cope with the dynamic changes within the anterior chamber. Now, the first type of the pumped infusion or pumped fluidics is the adaptive fluidics. Now, this adaptive fluidics is invented by Bausch and Lomb by the Stellaris Elite Vision Enhancement Vision System, and it is based on the principle that the system will proactively anticipate the fluctuation of the pressure within the anterior chamber, and accordingly it sends a signal to inject air in the infusion bottle so that the pressurized irrigation fluid will enter to the anterior chamber. Now, by this method, it proactively anticipates the occurrence of surge and mitigate against the surge by injecting the air. It is unlike the active fluidics in the Alcon system, in which it is not anticipating the surge, but once the surge happens, within milliseconds, the system will react and inject, or it will press on the motorized plates to inject the irrigation fluid inside the anterior chamber. However, in the Bausch and Lomb, it proactively reacts, so it anticipates the occurrence of surge and react accordingly. It doesn't let the surge to happen. Now, the advantage that it will keep the pressure within the anterior chamber high, and this will keep a deep anterior chamber and maintain stability of the anterior chamber during the whole procedure. However, the disadvantage of high pressurized operation is, as you know, that when the pressure is high during the whole operation, now there is a risk for the corneal endothelium and falls in the distal membrane post-operatively. Also, this will exert a stress on the zonule and also hydration of the vitreous, and of course, risk of posterior capsule rupture, and also ischemia to the optic nerve and damage to the optic nerve as the intraoperative pressure is high. So this is one type of the pumped infusion is named as adaptive fluidics, invented by Bausch and Lomb company. Now in the next slide, we will see the active fluidics by Alcon, and we will explain the difference between the adaptive fluidics and the active fluidics by Alcon company. Now, as we have said in the adaptive optics, that the system will proactively anticipate the surge, and accordingly, as a protective measures, it injects air inside the irrigating fluid, so that this air will pressurize the pieces inside the anterior chamber. Now, the disadvantage of this maneuver is it keeps the intraocular pressure high during the surgery, and this carries the risk of certain complications, as I will mention here. The famous one is the whip-out syndrome, although this is a rare syndrome seen in advanced glaucoma cases with advanced visual field changes and commonly seen after a trabeculectomy, but also those patients who underwent this sort of operations with high intraoperative pressure are at risk of this whip-out syndrome. Also, the procedure would be painful, especially in people with high axial length, people with high myopia, due to the stress in the zonule and in the lens iris diaphragm. So this fluctuation in the intraocular pressure is painful to the patient. Another thing, that the high incidence of iris lens or lens iris diaphragm retropulsion, especially in post-vitrectomized patients and in high myopia. Also, the compromised anterior segment because of the high intraocular pressure. This leads to increase in the Descemet's faults in the cornea, increased incidence of corneal edema, and the post-operative inflammation is more after the surgery. Another thing is, of course, the stress in the zonule, and the risk of tear in the zonule is more because of this high intraoperative pressure, and also hydration of the anterior vitreous face, and even rupture of the anterior vitreous face. All these side effects of high operation surgery make the doctor think for a better maneuver to have a physiological intraoperative surgery or a mild supra-physiological intraoperative surgery rather than high, sub-high intraoperative pressure. That's why in the next slides I will speak about the adaptive optics that actively monitor the intraocular pressure fluctuation based on special sensors. I will speak on this in the next slides. Another example of the pumped irrigation is the one which is invented by Alcon company, known as the active fluidics. In the active fluidics, it senses the changes in the pressure in the post-occlusion surge, and immediately it sends a signals through the cassettes, which has two sensors, one for the vacuum and one for the intraocular pressure. And this in turn will stimulate two plates electrically controlled, so they will make a pressurized compression on this bag, and accordingly the infusion pressure will be elevated. So another way recently invented in the Centurion is the what's called the active Sentry. Now the active Sentry is a built-in pressure sensor that it senses the intraocular pressure, and when there is any deviation from the target intraocular pressure, it will send signals to the cassette, and from the cassette it will stimulate this pressurized plates to maintain a target intraocular pressure. So this is a dynamic fluctuation and control of the intraocular pressure. So the moment by moment during the whole time of the surgery, any deviation of the target intraocular pressure, it is controlled by this active fluidics. You can see in this animation that how the active fluidics is stimulated. The bag is placed between two pressurized plates so that whenever needed, there will be stimulation and increase the intraoperative pressure. Here, the pump system linked with the sensors within the that may detect the vacuum changes and the intraocular pressure, and accordingly, it will send the signal to these plates so that it monitor the intraoperative pressure continuously during the whole stages of the surgery. And this is the active Sentry, which is a built-in sensor within the handpiece. This is active Sentry handpiece, so that it do the same thing. So during the whole stage of the operation, you can have or set a target intraocular pressure. Now you can see here from this curve, this is from the old technology, that's the Infinity, how the post-occlusion surge, when it happens, a marked drop in the aqueous from the anterior chamber because of the high vacuum in the system. However, when the introduction of the active fluidics, as in Centurion, the post-occlusion surge has markedly reduced by this technology. So this is another system in contrast to the adaptive fluidics in the pouch and lobe. This is an active fluidics by Alcon company. Now, the innovations of active fluidics and the presence of active Sentry handpiece by Alcon make the doctor and the possibility to adjust the intraoperative pressure and add another spectrum for the Phacodynamic, that you can set a target intraoperative pressure. Now, many studies done for setting a target intraoperative pressure, and it was found that it is useful in different indications to use different target intraoperative pressure. You can use a physiological intraoperative pressure or supraphysiological intraoperative pressure, or you can use a sub-high intraoperative pressure in certain limited indications. For example, a physiological intraoperative pressure with 18 millimercury to 22 millimercury pressure with a flow rate between 23 to 26 was found to be useful in advanced glaucoma cases and in patients with posterior polar cataract and in patients with benign prostatic hypertrophy using the tamsulosin drug for the prostatic hypertrophy. And you know, this drug will affect the iris and causes iris prolapse, and also in the anterior capsular tear. Now, a supraphysiological, a little bit more than the physiological IOP, between 23 to 34 millimercury, was found to be useful when you do trenching and you just have a small cut in the posterior capsule, or you can use it in high myopia and patients with zonulopathy. Now, the supra-high intraoperative pressure, more than 35 millimercury, was found useful in hard cataract with increased lens thickness and also in patients with shallow anterior chamber. So the setting of a target intraoperative pressure is now amenable by the advancement in the technology of phaco emulsification and by the innovations of the active Sentry handpiece that moment by moment monitor the changes in the intraoperative pressure, and accordingly it will inject a pressurized irrigating fluid so that facilitate doing the operation. So this possibility now is available by the innovation of a new Phaco technology. Another innovation in the Phaco fluidics is the one which is invented by Johnson & Johnson, which is previously known as AMO, is known as the on-demand fluidics. On-demand fluidics means that the system is incorporated with both dual pumps, that's Venturi pump and Peristaltic pump, and the surgeon will have the choice to choose between the two pumps on a fly, and according to the stage of the operation and according to the need of the surgeon, he will shift between peristaltic and Venturi pump. For example, as you can see here, in the beginning of the operation, he can, whether he is using the trenching method, so he can use the peristaltic pumps, and when he shift to quadrant removal where he need a high vacuum, he can use the Venturi pump and so on. So this offers good opportunity for the surgeons to use both the Venturi and Peristaltic pumps on demand. So this is called in-demand fluidics. Another thing new innovated in the Johnson & Johnson Phaco machine is what's called the chamber stabilization environment software, which is the case software. This software is meant to cope against the occurrence of surge. So that this is called occlusion mode. This occlusion mode is activated upon activation of the trigger. So the surgeon, he will set the standard parameters for his surgery, and also set a trigger for activation of the occlusion mode. Once this occlusion mode is activated, the whole parameters of the machine will be changed from the high vacuum and high aspiration flow rate to a low vacuum and low aspiration rate. Also, it will modulate the ultrasound power energy. For example, if the standard parameters of the doctor is around 400 millimercury of vacuum, and the trigger will be set, for example, at 390. So once the vacuum reaches to 390, this will activate the occlusion mode, and the vacuum will be changed to 200, and the aspiration flow rate will be changed, and the power of the ultrasound will be changed. So this is called the activation of the occlusion mode based on the trigger set by the surgeon prior to the surgery. So this is another innovations in the Johnson & Johnson Phaco machines. The fourth type of pumped irrigation innovated by one of the Swiss companies known as the Sophie pump system, or the triple pump fluidics. This triple pump fluidics based on incorporation of 3 pump systems in a single Phaco machine. One pump, peristaltic pump, to maintain and control target intraocular pressure, and another peristaltic pump for the traditional Phaco emulsification procedure, and a third Venturi pump to clear the emulsate safely, so that it will not be contaminated by the air and carries the risk of infection inside the eye. So there is 3 pump systems, 2 peristaltic and 1 Venturi system, and it is based on very proper monitoring of the intraocular pressure by special sensors. Once the fluctuation in the intraocular pressure, especially in the post-occlusion surge, within a milliseconds, this sensors will send a signal to the peristaltic pump to move more faster to inject active irrigation inside the anterior chamber to maintain a stable anterior chamber. So this system is known as the Sophie. Sophie stands for Swiss Ophthalmic Innovations. Swiss Ophthalmic Innovations. So this is another recently innovated pump system I like to mention about. Another recent innovation in the pumped irrigation is known as the Nexus Fluidics, and this invented by Door company, and it is some sort of pumps in which both Venturi and peristaltic pumps are working simultaneously, and automatically the machine will shift between the peristaltic and Venturi pump based on the preset value of the vacuum and the speed of the aspiration flow rate. And this is particularly useful in both anterior segment and posterior segment surgery, in which in some situations you need a very high cutting rate in the vitreous with low vacuum, and sometimes you need a high vacuum with slow cutting rate. Now you can see here that there is a set of sensors here that automatically will work, so that it will shift the machine automatically between peristaltic and Venturi pumps at the same time, so that you will have a very stable anterior chamber and stable fluidics during Phaco emulsification. This innovations is made by Door company, known as the Nexus Fluidics. It is a combination of both peristaltic and Venturi pumps at the same time. Now to remind you what we have finished so far, we have finished the ultrasound power and ultrasound power modulation. We have finished the passive and active irrigations, and now we are coming to the aspiration and aspiration flow rate and the different types of pumps. Now we come to the second important parameter in the Phacodynamic, which is the aspiration or the aspiration flow rate. Now this function is activated once we step down the foot pedal in position 2, so that we will activate the pump. And based on the type of the pump you are using in the system, now you have both variables, the aspiration flow rate and the vacuum. If you use a peristaltic pump, usually you have a direct control in the flow rate and the vacuum is indirectly controlled. And if you use a Venturi pump, you have a direct control in the vacuum, and the aspiration flow rate will follow and indirectly be controlled. And the main function of the aspiration flow rate is mainly 3 points. It clears the emulsate from the anterior chamber after the emulsification of the lens nucleus. So you need to remove and wash this emulsate from the anterior chamber. This is done by the aspiration and the flow rate. The second thing is that the aspiration flow rate determines the speed by which the events happens within the anterior chamber. So the speed by which the fragments are attracted to the lens, to the needle, is determined by the aspiration flow rate. So the more the aspiration flow rate, the more the fast the speed for the events within the anterior chamber. The third important factor is that once occlusion happens, the vacuum will develop and build up. So this will provide a very good holding power for the Phaco needle. So the aspiration flow rate provides cleaning of the anterior chamber, provide good attractability and followability for the lens fragments, and provide good holding power once vacuum has been established. You can see in this video, this is the aspiration flow rate. The speed by which this fragments is attracted to the lens, to the Phaco needle, is determined by the aspiration flow rate. The more the aspiration flow rate, the more fast the events will be within the anterior chamber. And here, once the occlusion happens, now the vacuum will build up and provide a very good holding power for the lens fragments. So the vacuum is the negative pressure created by the pump once occlusion of the tip is there, and this is true for the peristaltic pump. However, for a Venturi pump, the vacuum will be present even without occlusion of the Phaco tip. And in the peristaltic pump, we have to determine the aspiration flow rate before surgery, and the vacuum will follow. So the vacuum will be indirectly controlled. And the rising time refers to the time by which the machine will reach to the preset value. The more, the faster the pump, the more, the shorter the rising time. So if you set the vacuum, for example, 300, you need, for example, 2 or 3 seconds to reach to the 300 upon complete occlusion. So if you make the aspiration flow rate more faster, so the rising time will be more shorter. There are different pump system has been invented from the origin of the Phaco emulsification till now. The most famous and the most common is the peristaltic pumps and the Venturi pump, and now recently the speed pump by Ortley, and also there is the hybrid pumps that utilizes both the peristaltic and Venturi principle, and the Quattro pump, which is invented by Zeiss company, and also the diaphragmatic and rotary van pumps. Now, in this lecture, I will just concentrate on the first 4 types. That's the peristaltic, the Venturi, the speed, and the Quattro, and the hybrid pumps, because they are important. The other rare type of pumps, like the diaphragmatic pump and the rotary van, we will not discuss about these pumps. The first and the most common of the aspiration pumps is the peristaltic pump, and the name peristaltic was inspired from the movement of the small intestine. So it is made up of a set of rotating wheels. These wheels, when they move, they will pinch segment of the aspiration tube, so that this will make milking of the fluid within this tube and create an aspiration flow rate. Now, this peristaltic pump has a direct control over the flow rate. So the more the speed of the pump, the more will be the flow rate. And the flow rate represents the amount of fluid removed in millimeter per minutes. And the other variable that control is the vacuum. Once there is occlusion of the tip, the vacuum will be built up. However, in the peristaltic system, there is no direct control of the vacuum because the vacuum will appear only once occlusion takes place. Without occlusion, there will be no vacuum, just only an aspiration flow rate. And once the vacuum established, there will be it will reach to the preset value based on a rising time, but actually we cannot interfere with this rising time, and we cannot interfere linearly, that's decrease or increase this vacuum. That's why we say that in the peristaltic pump we have a direct control over the aspiration rate, but we have indirect control on the vacuum. And of course, the vacuum will be dependent on very different variables. One of them is the aspiration flow rate. The more the aspiration flow rate will be, the more the vacuum reach to the preset value very fast, and the short of the rising time. And also it depends on the resistance to the outflow. If you have wide Phaco needle or Phaco tip, the resistance will be low. If you have a very small or micro tip, the resistance will be more. And also depends on the compliance and the diameter of the aspirating tubes. If your tubes are very compliant, so there will be a chance of surge and collapse of these tubes. However, if the tubes are less compliant, now the chance of surge and the complication from this vacuum will be less. So this is one of the most common types of pumps, is known as the peristaltic pump. As you can see here in this animation, the movement of the wheels, and as the wheels are moving, it will create a milking effect on the aspirating tube and will create the aspiration flow rates. The second type of the aspiration pump is the Venturi pump, also known as vacuum based. And this is one of the most common types of aspiration pump. The principle behind is related to the Venturi principle, which stated that when a pressurized gas pushed through a wide lumen tube to be passed through a small lumen tube, this will create a vacuum as it is connected to the tank here or to the canister, and this vacuum will draw the water and aspirate the water from the anterior chamber. So in this type of pumps, the vacuum is the prime force and is the prime one that's directly related by the linearly controlled by the foot switch of the surgeon. However, the aspiration flow rate will be indirectly controlled. Usually there is a ratio of 10 to 1, that's for each 10 millimeter of mercury vacuum developed, there is one aspiration flow rate. For example, if you have 300 preset value of the vacuum, so by reaching to this level, you will have 30 cc per minute aspiration flow rate. So the feature of the Venturi pump that is generated, as I said, in the canister, and this will depend, the vacuum will depend on the tubing. As the tubes are compliant, so less vacuum will be developed and there will be collapse of the tube. However, a non-compliant tubing is very important to maintain the vacuum, and the speed of this vacuum is very high. The rising time is very high as compared to the peristaltic pumps, so that once you start and put your foot in the foot pedal in position 2, the vacuum will be rapidly and linearly controlled with a very short rising time. And it should be noted here that there is no zero vacuum. That's once you press, it will start immediately. So there is no zero vacuum phacoemulsification in this type of pumps. Also, as I said, that the flow rate is always proportional to the vacuum, and we primarily control the vacuum. However, indirectly we control the aspiration flow rate. And this type of Venturi pump is one of the most common pump used especially in the posterior segment surgery. And since it is very fast and very strong vacuum creation, it is advised for a junior doctor or who are still learning the principles of phacoemulsification not to use this type of pumps, and it should be restricted for trained and experienced doctors to use this type of pump. Most of the recent phacoemulsification machines now, they include this Venturi pump in them. And in this animation, I will show you exactly how it is produced. You can see here that the air is pushed from the side with very high speed, and the vacuum will be created here and draw the water through this tube. This slide summarizes what we have spoken before regarding the difference between the flow-based pump, that's the peristaltic pump, and the vacuum-based pump, which is the Venturi pump. As I said, that in the presence of non-occluded Phaco tip, the vacuum will be very low in a peristaltic pump because the vacuum will start only once the occlusion of the tip is there. However, the flow is high because the peristaltic pump directly controls the flow. So we can preset the value of the flow and linearly controlled by the foot switch. However, in the Venturi pump, the vacuum and the flow will be high from the beginning, and this is one of the main difference. And in the Venturi pump, the primary control is the vacuum, and the flow will follow the vacuum. That is indirectly controlled, as I said, by ratio of 10 to 1. In the presence of occlusion, now the vacuum will start to build up and becomes high in the peristaltic pump, and the flow will be reduced because there is occlusion of the tip and obstruction of the aspiration line, so that the flow will be reduced. Similarly here, even in the Venturi pump, the same thing will happen. And from this problem, that's the slowdown of the flow rate, some problems might arise like the post-occlusion surge and the thermal effect of the phaco needle. And in the next slides, we'll speak about the measures done by different companies to avoid and overcome the problem of post-occlusion surge. Here, I would like also to mention some other types of flow-based pumps and vacuum-based pumps. Apart from the classical peristaltic pump, the scroll pump is also another example of a flow-based pump. And the Venturi pump, another example, is the rotary van, and the membranous pump also is a sort of vacuum pump. Another type of pump system which is invented by Ortley company, which is known as the speed pump, and this speed stands for speed and precision. It is simply physically like the peristaltic pump, but already the speed is set to start with very high speed initially, and once you press in the foot pedal, a very high speed of the pump will start, so you'll have immediate high aspiration flow rate. And once you occlude the tip, the vacuum will very rapidly reach to the preset value, as you can see in these animations, that we set the vacuum at 600 and we set the aspiration flow rate as 50. You will see that once we start and step down the foot pedal, the flow rate will immediately rise and the vacuum will be rise. And moreover, you will have a linear control for both, for the peristaltic, for the aspiration flow rate, as well as for the vacuum. So once you release your foot from the foot pedal, the vacuum will drop down. So you can see in this animations that once pressing the foot pedal, as you can see here, you see the vacuum and the aspiration. This is the preset value. So once pressing the foot pedal down, so immediately the pump will start with very high speed. As you can see, the aspiration flow rate will go very fast. And now the vacuum is not built up because no occlusion. Once he occluded the tube for the aspiration, you see the vacuum immediately within seconds, it reached to the preset value of 600. And similarly, when he releases foot, now the vacuum dropped down. You see, so there is a linear control for both, for the aspiration flow rate as well as for the vacuum, which is peculiar to this type of pump. So it takes the advantage of both of the Venturi system, with that you can utilize a very high vacuum, and utilizes a linear control for both for the vacuum and aspiration flow rate. So this is a special type of pump characteristic for Ortley system. As I said, that it can be even applied for retinal surgery because of this high vacuum, and you can do peripheral vitrectomy with this very precise and very speed pump. That's why it's known as speed pump, because it is very fast. That's speed and precision. The fourth type of the aspiration pump is newly invented by Zeiss company, known as the Quattro pump or the Quattro flow pump. And this was invented in the Quatera 700 Phaco machine from Zeiss, which recently launched in the market. This type of pump is it uses both the vacuum and the aspiration flow control, and gives a very high rate of vacuum reaching up to 700 millimeter of mercury, and flow rate reaching up to 120 cc per minute. And the idea or the principle behind this type of pump is it is similar. It was originally invented from the action or the function of the heart. So it is made up of four diaphragm with the 4 chambers, and these chambers are moved synchronously so that they will transmits the vacuum and the pressure from one compartment to other compartment. So smoothly it will build up the vacuum and the draw the flow rate. So the idea was invented from the function of the heart. So this is the quattro pump. As you can see here in this animation, this is the diaphragm, and this movement will smoothly create a vacuum and a flow rate that will be translated or transmitted to the anterior chamber. Another type of the aspiration pump is what's known as the diaphragm pump. This based on the principle that there is a flexible diaphragm which is connected by a bar to a wheel. When this wheel moves, will pull this bar away, so they create a vacuum here. This valve will be open, and this will create a vacuum that will draw the fluid in this tank. Now, when the same wheel rotate and it goes down, so this valve will be closed and it will open. The drainage valve here will open, and the drainage will go out. Of course, this is done with very high speed. So this is another type of pumps known as diaphragm pump. Is not commonly used nowadays as compared to the Venturi and Peristaltic pump, but I like to mention that this is one of the pump systems which was available in different types of Phaco machines. To revise with you what we have taken so far, we have finished the ultrasound power and ultrasound power modulation, and the passive and active irrigation, and the aspiration flow rate, and the different types of the pumps. In the next slides, we will speak about the vacuum and the surge and the anti-surge measures, and all the precautions to avoid the surge. Now, to have a better understanding of the post-occlusion surge management, there are two variables or two definitions very importantly to understand them: the followability and the holdability. Now, the followability, and also named as the attractability or the ability of the or the tendency of the lens fragment to be attracted by the phaco tip, and this is known as the followability, and it is a function of the aspiration flow rate. The more the aspiration flow rate, the more will be the followability. And this is related to many variables. The main is the eddy current created by the infusion fluid. As you can see here, that the infusion fluid will create an eddy current. This eddy current creates a zone of a good followability, which is shaded in green, and zone of poor followability, which is shaded in yellow, and zone of no followability, which is in gray, in this one, which is subincisional zone. By moving the phaco tip, so you can improve the zones of your followability. Now, this followability is very important, especially in cortex removal and in fragment emulsification, so that the fragment is following the phaco tip rather than the phaco tip is following the fragments. Now, you can see in this animation what's the meaning of the eddy currents, as you can see here in this animation. This is related to the infusion sleeve, so the opening will may create an eddy current. This eddy current will help to attract the lens fragment toward the phaco tip, to bring it to the phaco tip to be engaged by the phaco tip, and then the vacuum will play the role in holding this lens fragment. So both the holdability and followability are interrelated. The followability brings the lens fragment towards the phaco tip, and the holdability related to the vacuum. Once there is a full occlusion of the phaco tip, now there will be a good grip for the lens fragment, and then it will be emulsified by the ultrasound. This is the ideal way for good phaco emulsification. So you have to have a good vacuum and good aspiration rate for a good phaco emulsification procedure. Okay. Now, the second term that you should understand is the meaning of holdability, or it is known as the power of a grip. It is the function of the vacuum that provide the holding power of the phaco tip for the lens fragment. The ability of the lens fragment, the ability of the phaco tip to hold the lens fragment and move it. This is the holding power. And for a good holding power, you need, or there are certain variables determine the holding power of your phaco tip. One of them is the vacuum. The more the vacuum is, the more the holding power. This is very important. And also the design of your tip. That's to say the angulation. The more angled the tip, the less the holding power, because there will be no good occlusion. However, the smaller the angle the phaco tip, the more holding power, because the good occlusion. The other thing is the surface area of the tip. The more the surface area, the more the holding power. So if it is angulated phaco tip, but with good occlusion, now you will have a good surface area, so you will have good holding power. The other thing is the ultrasound mode, or the duty cycle. The more the duty cycle, the less the holding power, because the less the off time, as we have spoken in the lecture of the ultrasound modulation. The smaller the duty cycle means the large off time, so that the off time gives a chance for the vacuum to build up and gives you a good holding power. So as you know, the vacuum will be created in the peristaltic pump upon occlusion. So you have to have a good occlusion for the vacuum to build up. So to have a good holding power, you have to engage the impale the phaco tip inside the lens fragment, so that you have a good occlusion. And for Venturi system, you need not to have a full occlusion, because the vacuum is already present even without occlusion, but then the vacuum will increase more with the full occlusion. Okay, so you can understand that the holdability and the followability is a balance between the aspiration flow rate and the vacuum level. The more the aspiration flow rate, the more will be the followability, and this is needed in during the stages of lens fragment removal, and also in the cortex removal. And the holdability is a function of the vacuum. The more the vacuum, the more the holding power, and you need this in stage or first stage of phacoemulsification, where you want to do a direct chopping. You need to have a good holding power of the lens, and also for quadrant removal, you need to have a good vacuum for quadrant removal. So the holdability and followability is very important variables that determines and affect your surgical procedures. Now we come to one of the most feared complication that might face the surgeon during the operation, which is the surge. Now the surge is the reverse of stability of the anterior chamber. When we say the surge, it means that there is a huge phacodynamic imbalance that leads to sudden gush of fluid to the phaco tip and collapse of the anterior chamber upon overcome the obstruction of the phaco tip. And this surge is related to many factors, related to the tubing system. That's you are using less compliant tubing, so they will collapse upon high pressure like this. When there is obstruction of the aspiration line, the vacuum will build up. So if your tubes are compliant, they will collapse. And once the obstruction is overcome, as you can see here, so there will be sudden expansion, and this will absorb water, absorb the fluid from the anterior chamber, and this will lead to collapse and instability of the anterior chamber. Also, it could be related to the tubing lumen. Normally, the irrigation line should be wider as compared to the aspiration line. So if the aspiration line is wide or is not that narrow, so the aspiration of the fluid of the anterior chamber will be very high. Also related to your parameters, if you are using a very high vacuum setting and high aspiration rate, the risk of surge will be more. Now I will show you in this animation how the surge will occur. Now once the occlusion of the phaco tip, as we explained in the peristaltic system, now the aspiration flow will stop, and the vacuum will build up. Now once the obstruction of the phaco tip is overcome, now there will be sudden gush of fluid, because the pressure difference between the anterior chamber and the tubing system, so that there will be sudden aspiration of fluid to the aspiration line, and this lead to imbalance and collapse of the anterior chamber. Now this imbalance and this collapse of the anterior chamber will lead to complications. The main complication is the rupture of the posterior capsule, but also it will lead to damage to the endothelium. So in all the companies and all the recent machines, they compete to offer you a very stable anterior chamber, and we can select between the machines based on the stability of the anterior chamber. And the stability of the anterior chamber means that there is no risk of surge. So in the next slides, we'll speak about the anti-surge measures that should be followed either by the surgeon or it should be available in the machine so that to minimize the risk of occurrence of surge and offer a very stable anterior chamber. One of the important measures to manage the post-occlusion surge preoperatively that you should take care of your tubing system and the irrigation tubes and the aspiration tubes should have specific features. The irrigation fluids should have a wide lumen with a thin wall and more compliant so that it allow more gush of fluid into the anterior chamber. However, the aspiration line should have a thick wall and less compliant and a narrow lumen and can withstand high vacuum pressure. So this is ideally should be the aspiration line. And usually it is noted in red color, the aspiration line, and the green color is the flow or irrigation line. So you should not use the wide tubes for the aspiration line because this will endanger the anterior chamber and the risk of surge will be very high. As you can see here, when there is an occlusion, this is a compliant tubes. If there is occlusion, these tubes will collapse, and this collapse will make the risk of surge is high because once the occlusion dislodged, there will be expansion, sudden expansion, and this will gush the fluid from the anterior chamber. And you can see here the relation between the compliant tubes with different pressure variables. If the vacuum is 100 or 150 or 250, you will see the post-occlusion. Once the occlusion is overcome, you see the sudden drop of the pressure and then it returns back. So the more the pressure or the vacuum in the preset value, the more the risk of surge in this type of a tube. So one of the important measures is to make sure that your tubes are non-compliant and you are using the ideal tubes for the irrigation port and for the aspiration port. Now we come to the second measures that counteract against the occlusion surge, which is usually most of the recent and modern Phaco machines are equipped with this facility is known as the venting. And the venting is simply means the injection or bleeding of an air or fluid within the aspiration line to neutralize the vacuum in the aspiration line to the preset value. Now, when there is an occlusion of the Phaco tip, the vacuum will build up in the system and it will reach up to the preset value. The system is programmed so that prior to the preset value, there will be opening of the venting valve, and this valve will inject an air or fluid so that it will neutralize this pressure, so the vacuum will drop down. The reason why, because we don't want the high vacuum here. Once the occlusion is bypassed, now this vacuum will be transmitted to the anterior chamber and create imbalance and turbulence, and this will lead to the surge. And in a step to overcome this problem, the venting valve will open so that neutralize the pressure here. This allow for the disengagement of the lens fragment and to be re-engaged again and so on. Now, sometimes even with this venting process and with the pressure of 0, still the fragment is still engaged in the Phaco tip and cannot be released. And at that time, you need to activate the reflux action of the foot switch, as we have spoken before about the reflux action. Now, this is a reverse action that you will make the pump to remove in the opposite direction, so that the reflux action will repel the fragment which is engaged in the Phaco needle. Or you need to sometimes to use the second hand to assist in removing the lens fragment from the Phaco needle. So this is the meaning of venting, and usually is activated once you release your foot from position 3 to position 2 to position 1. This will automatically will activate this venting process in most of the system. And another point, the need for the venting system in peristaltic pump is much more than that of the Venturi pump. Because in Venturi pump, we usually use a rigid cassettes with a very non-compliant tubing. The need for venting is less in that system as compared in peristaltic, in which we use a non-compliant tubing, however, but it is not that stiff like in the Venturi pump. The reason why, because if you use a very stiff tubes here, you will interfere with the function of the peristaltic pump. As you know, the principle of the peristaltic pump based on the compression of the tubes that result in milking and creation of an aspiration flow rate. Now, if the tubes are very stiff, now this function will be interrupted. So we need to use a stiff, but what known as a compliance. That is stiff to some extent, but it is not that stiff, so that will not interfere with the function of the peristaltic pump. That's why the need for venting in peristaltic system is much more than in Venturi system. So this venting process is one of the measures that acts against the surge and usually present in most of the recent machines and usually activated automatically when you retract your foot from the foot switch from position 3 to position 2 and then to position 1. Another method to protect from the post-occlusion surge is the presence of special modification of the Phaco needle, which is known as the aspiration bypass system. Now, the aspiration bypass system, first invented by Alcon company, based on the principle that there is a small opening in the shaft of the Phaco needle underneath the silicone sleeve, so that when there is a total closure of the tip and the vacuum buildup here, so as you know, when there is total occlusion of the tip, there will be no any flow of materials, and this will lead to elevation of the temperature of the Phaco needle, and the vacuum will build up too much to the preset value, so that when this fragment is dislodged, there is a chance of the sudden gush of aqueous from the anterior chamber to the needle and lead to the surge. Now, the presence of opening, there is a small valve which at particular level it will open so that it allow the fluid to be irrigated from the irrigation line to the Phaco needle, so that it reduces the temperature as well as it prevent the reaching the vacuum to the high preset value and total cessation of the flow. So by this way, there will be no total cessation of the flow, and still there is some fluid is coming even with total occlusion of the tip. Another modulation of the Phaco needles to overcome or counteract the effect of post-occlusion surge is the creation of micro tips or micro needles that is increase the outflow resistance, so that when we increase the outflow resistance along with increase in the inflow of the irrigation fluid, all these factors will maintain the anterior chamber stability and prevent the collapse of the anterior chamber. So this is among the measures that is utilizing the Phaco needles to counteract the post-occlusion surge or management of the post-occlusion surge, is the presence of the ABS needles and also the micro tip technology to counteract the post-occlusion surge. Another method to protect from the post-occlusion surge is the presence of special modification of the Phaco needle, which is known as the aspiration bypass system. Now, the aspiration bypass system, first invented by Alcon company, based on the principle that there is a small opening in the shaft of the Phaco needle underneath the silicone sleeve, so that when there is a total closure of the tip and the vacuum buildup here, so as you know, when there is total occlusion of the tip, there will be no any flow of materials, and this will lead to elevation of the temperature of the Phaco needle, and the vacuum will build up too much to the preset value, so that when this fragment is dislodged, there is a chance of the sudden gush of aqueous from the anterior chamber to the needle and lead to the surge. Now, the presence of opening, there is a small valve which at particular level it will open so that it allow the fluid to be irrigated from the irrigation line to the Phaco needle, so that it reduces the temperature as well as it prevent the reaching the vacuum to the high preset value and total cessation of the flow. So by this way, there will be no total cessation of the flow, and still there is some fluid is coming even with total occlusion of the tip. Another modulation of the phaco needles to overcome or counteract the effect of post-occlusion surge is the creation of micro tips or micro needles that is increase the outflow resistance, so that when we increase the outflow resistance along with increase in the inflow of the irrigation fluid, all these factors will maintain the anterior chamber stability and prevent the collapse of the anterior chamber. So this is among the measures that is utilizing the phaco needles to counteract the post-occlusion surge or management of the post-occlusion surge, is the presence of the ABS needles and also the micro tip technology to counteract the post-occlusion surge. Some of the phaco perils that I would like to mention here before I finish this lecture is that usually the ratio between the vacuum and the aspiration flow rate is set around 10 to 1. That is, if you have a vacuum of 200 millimercury, the aspiration flow rate will be around 20 cc per minute. And if you have a vacuum of 300 millimercury, the aspiration flow rate will be around 30 cc per minute. And this is true for peristaltic pumps because, as I explained before, that in peristaltic pump, you can set the vacuum and the aspiration flow rate separately and preoperatively. However, this is not applicable in Venturi pump because you only one parameter to adjust, which is the vacuum, because the aspiration flow rate will be following the vacuum. But you cannot set the aspiration flow rate before surgery in Venturi pumps. Now, the exception for this rule is that in trenching, you need a low aspiration flow rate, but very low vacuum because you don't need to fix the nucleus and you don't need to move the nucleus. And also in direct chopping, you need a very high vacuum, which is around 350 millimercury, and you need low aspiration flow rate because you need to do a direct cracking. Now, it is roughly estimated for a micro tip needle in a Venturi system, if you make the vacuum of 50 cc, 50 millimeter of mercury, you have 17 cc per minute aspiration flow rate. If you have a vacuum of 100, you will have 23 and so on. Now, the interchange between peristaltic and Venturi system is not allowed. So if you have your setting in a peristaltic system, it is different than Venturi system. So you have to personalize your setting in different systems, also in different machines. So your setting in Alcon differs than your setting in Bausch and Lomb and so on. So you have to customize your setting based on the pump system you have and based on the system you are using. Before I finish this lecture, I would like to explain or speak about the audible clues. You know, the phacoemulsification machine, it is an art that the surgeon uses all his sensation at the same time. So he uses the right foot in the foot pedal of the phaco machine and the left foot in the foot pedal of the microscope, and also the right hand using the phaco handpiece and the left hand for the second instrument, the chopper or the Sensky hook. And he uses his eyes to watch through the microscope, and you use your ears to listen to the audible clues provided by the machine to indicate at which stage you are in the irrigation or in the aspiration or in the vacuum stage, or when the vacuum reaches to the highest level of the preset value. So you listen the peeps for this, indicating that you are reaching to the maximum preset value. All these audible clues are very important that help the surgeon to know at what stage he's during phacoemulsification. Also, the tactile sensation present in the foot pedal, the sensation of opening of the pinch valve when you step down from position 0 to position 1, and also the tactile sensation when you step down to position 2 and then to position 3. All these use it synchronizedly together. So the phacoemulsification is an art that you can use all your sensation at the same time. By the end of this lecture, I thank you very much for your listening for this lecture. I hope that you get benefited from this lecture, and a good surgeon who's understanding the phacodynamics of your machine and the principles behind your machine, and who can tackle any worst scenario that he can face during phacoemulsification surgery. So I hope by the end of this lecture that you get benefited, and I hope that I will meet you in another session and in another lecture. For that time, I hope that you will be safe, and thank you very much again.